So what I'm saying is like the target yield we fix, it varies, depends on the type of patients we cater. So, and it varies between the center to center. It's based on the hematologist practice also. So we need to assess what is our target before we even start the stem cell planning. So like the commonly we define the yield, CD34 yield. Patients are classified. This is in the autologous setting. So we classify them as an optimal collection when we get a 5 million CD34 cells per kg body weight. Low E collection when it is between 2 to 5 million, and poor collection when it is less than 2, and failed collection is where people did not mobilize. So we have a faced people who don't mobilize. So we consider mobilization failure when the peripheral blood count is less than 20 cells at the time of apheresis. On the day 5, when the peripheral blood CD34 count is less than 20 cells per microliter, we consider such individuals as poor mobilizers or failed for eligible for apheresis. So the commonly involved people who fail to mobilize are people who are greater than 60 years of age, who receive multiple lines of chemotherapy for their treatment protocol, or prior exposure to alkylating agents, or who received a radiation therapy on the bone marrows, and persons who are exposed to lenalidomide. We know lenalidomide is a particular drug which acts on the stem cell progenitor cells, so the mobilization efficiency is impaired. And people who have a lower baseline platelet count at the time of stem cell collection, they also mobilize very poor. So we need to identify such individuals also before even we plan, because we are going to know that these people are going to be poor mobilizers, and to achieve our target yield, we need to set our target volume process to be modified. So when we plan something, by default, so we usually keep conventionally, we keep 2 to 3 blood volumes of the patients as a target blood volume in an autologous setting. So when we expect some patient is a poor mobilizer who had a risk factor, we always have to consider their mobilization inadequacy. So we have to process relatively a large volume apheresis, leukapheresis. That is more than 3 blood volumes. When we process more than 3 blood volumes in the patient, we call them as a large volume leukapheresis. So when we set a target in a machine, like most of my presentations are with respect to Optia, because that is what most commonly followed in all the centers. So our primary targets, we can choose either of these 4. It can be based on the whole blood process, that you can set your volume in terms of whole blood process, or you can fix your time. So you want the donor to procedure to be completed in 4 hours or 6 hours. You can fix that also, or you can express in terms of TBV process. That is a fair method we usually do. So when in an autologous setting, it is always better to use a word TBV process. In an allogenic setting, it is always better to use a whole blood process. And collect volume. We know based on our patients what is the volume they can tolerate. That also. These are the 4 options where we can choose our target. So for in addition, if you want to do a cryopreservation, or where you want a concurrent plasma, that can also be added in your secondary target. So before you plan an apheresis, we are going to choose what values we are going to put for the patient in the machine. That is the first step we do in the technical aspects. So with respect to allogenic setting, the NMDP recommended apheresis setting in an allogenic setting, where I told the better will be a volume process, whole blood process. Whereas in autologous, it is total blood volume process. Whereas in an allogenic setting, we always look at the whole blood process volume. So they have defined at the recipient's weight. If the recipient weight is so much, so we need to process so much liters of blood. So that is what the NMDP says for an allogenic criteria. So what is the maximum we can process is 24 liters over a period of 2 days time. Beyond that, no blood volume should be processed in an allogenic setting. The other method to process is, we have a formula. It's called whole blood to process. So it is desired CD34 yield in million per kg body weight into body weight of the recipient divided by collection efficiency. That is the correction factor of the equipment. How good the equipment is able to extract the CD34 cells. That is collection efficiency. On an average, it ranges between 0.3 to 0.6 for all the Optia equipments, and the donor's peripheral blood CD34 count. For example, we are doing an autologous setting where I want 5 million cells from the patient. So we will put the value 5, and the recipient body patient weight is 60. So the collection efficiency of my equipment is 55%, that is 0.55, and the donor peripheral blood CD34 count in the morning was 50 cells. So we get somewhere around 11 liters of unanticoagulated blood. So when you do this one, no, we should always consider the whole blood process is always inclusive of ACD volume used. So you need to add that correction factor also. So for a 11 liters of anticoagulated blood, at the ACD usually use 1:12 as a ratio. So we would have used somewhere around 900 ml of ACD. So whole blood to be processed will be somewhere adding these two values, that is close to 12 liters. That's how we derive the value. What is the target for an autologous setting or an allogenic setting? I hope this is clear. So the next thing is, once you set your target, so we need to tell what layer we want to extract. So because we all know the blood elements has various specific gravity and they form layers as we centrifuge them in the FRCC equipment. So we are all were aware the plasma is the lightest one and the RBCs are the denser ones, and our mononuclear cells, that is our cells of interest, they are like thought to be like a lymphocyte like morphology, and they lie between the layer granulocytes and the platelets. So stem cells are like lymphocytes. So they reside between the granulocytes and the platelets. So we should put our efforts in trying to harvest between these two layers. So we like Optia equipment has different protocols. We all be aware of Optia. When you use an Optia, you will have understand that's a granulocyte collection, that's a continuous mononuclear cell collection, there is a platelet collection, there's a lymphocyte collection. These collection protocols, they differ based on their centrifugal force. So basically, when you in granulocyte collection, we know granulocytes are heavier molecules when compared to the other white blood cells. So we even a low G force is sufficient for granulocytes to sediment on the RBC layer, and the lighter elements like lymphocytes, monocytes, and platelets will be in the supernatant. So low G force is sufficient to get an interface for a granulocyte connection, whereas for platelets we want all the cellular bigger elements to settle. So we need to have a high G force for platelets, so that the platelets can be aspirated on the top layer, topmost layer. Whereas a mononuclear cell is a tricky one. So where it is between the monocyte and the monocyte and the lymphocyte layer. So we need to adapt a medium G force, and the interface has to be positioned properly. So because if you don't position it properly, you may end up in collecting from the RBC layer, or you're going to end up in collecting from the plasma layer. So that is a challenge with the mononuclear cell collection. So normally, Optia equipment for a continuous mononuclear cell collection, it uses a factor called packing factor. That is a density, like how good the cells are packed. It ranges between 1.6 at some point and 4.5 up to at the different points. So like for, you can see the values now. So you can see, so where we want to aspirate the cells. So that is the point of interest in stem cell collection. So we should not end up in aspirating the RBC layer, or we should not end up in aspirating the platelet layer. So we need to keep it somewhere around the monocyte layer. So our layers have to be formed in a better interface position. So what happens if you don't position your layer properly? So you end up in collecting contaminants. So contaminants in respect to stem cell collections are when you try to collect more amount of RBCs. When you go deeper in the collection, so you end up in collecting more RBCs. What happens? It may induce anemia in the recipient, or it may induce anemia in the donor. And what happens when you cryopreserve this product? These RBCs get sliced, and they are going to be toxic to the patients at that time of infusion. That is the problem with the red cell collection, collecting excess red cells. Or when you try to collect more platelets, when you collect more platelets, you are going to induce thrombocytopenia in the patients or in the allogenic donors. The other problem with the platelets is if you collect more platelets, it is going to induce clumping in the bag. So that is the second factor. So we need to try to minimize the platelet collection also. And the third thing is granulocytes. In a mononuclear cell collection, the least granulocyte is much preferred because granulocytes are toxic. They release cytotoxic granules, which may affect the viability of a cryopreserved product. So we need to try to minimize these contaminants and focus only on the mononuclear cell layer at the time of stem cell connection. So these are the challenges with respect to the interface position. So the other challenges are hypotensive episodes. So we know that if it is equipment, so blood is outside the body. So we are inducing some amount of blood loss in the recipient. So where they should be able to tolerate the blood loss. So it may induce hypotensive episodes. We will discuss about the extracorporeal volume in the subsequent slides. Then hypocalcemia, we know anticoagulant is being passed through, and vasovagal reactions are more pronounced in a setting of hypocalcemia. So that reaction is also more common. And we are also going to induce cytopenias. Either it can be anemia or thrombocytopenia as a complication of stem cell collection. So which equipment? All FRCC equipment which can collect WBCs can collect stem cells. So none provides better stem cells. The difference lies is with the difference in the extracorporeal volume are the other cells being harvested, contaminants being harvested, and the incidence of side effects, and the use of alternate anticoagulants to citrates. So we know in the market there are 4 equipments: Haemonetics, Spectro-Optia, Amicus, and Comtech. All these 4 equipments can do stem cell collection. They can do a good quality of stem cell product. The only difference happens is with the other cellular elements which we discussed before. So there will be excess contaminants in some, there will be less contaminants in some. So we need to focus on that part. So we all know that there's an intermittent flow system. We have a continuous flow system. So in intermittent flow, the blood is processed in batches. In continuous flow, it is an ongoing process. Because the blood is processed in batches, so the extracorporeal volume, that is the volume which is volume of blood which is outside the body at any point of the procedure, it is very high in an intermittent flow system. Whereas in continuous flow system, the extracorporeal volume is minimal. So pediatric procedures should always be preferred in a continuous flow equipment because of the large extracorporeal volume with the intermittent flow systems. Sorry, we are not giving pre-test. Okay. So, huh? Okay. Because I'm telling answers for all my questions. Okay. So the next one is when you plan, no, like when you get a patient data before when you accept a patient for apheresis, you need to get the patient's demographics, like patient's height and weight, and you need to determine what is the extracorporeal volume. What is extracorporeal volume? That is the volume of blood removed from the donor or patient at any time. It includes blood, plasma in the collection packs, and all within the blood like equipment circuits. On an average, the extracorporeal volume ranges somewhere between 140 to 450 ml, depends on the equipment as well as the procedure. For the same equipment, for different procedures, the extracorporeal volume changes. I hope you understood. So what is the problem with this one is, so during the procedure, intra-procedure, there will be a negative fluid balance. Whereas at the end of procedure, there will be an excess positive fluid balance in the patient. Because during the procedure, you're going to use those blood for filling your circuit. So there is a negative balance. At the end of the procedure, you're going to push all the things back to the patient. So there's a positive balance. So you need to know whether the patient will tolerate both this setting, intravascular loss as well as the post-procedure loss, like gain. So this is some examples for a extracorporeal volume. This was for a like the topic for today is stem cell collection with respect to Optia. So I will restrict to Optia. In Optia, so for a continuous mononuclear cell collection, so the extracorporeal volume is around 300 ml. So and mononuclear cell collection, there is an alternate protocol called mononuclear cell collection, which has 196 ml. So now they have stopped mononuclear cell collection in Optia. Now it is only continuous mononuclear cell collection. For a Haemonetics, it is somewhere beyond 350 ml to 400 ml. And for Comtech, it is 197 ml, I believe. So the extracorporeal volume changes for each patient. So you identify what is your extracorporeal volume for your procedure. For example, CMNC is the one commonly performed. So now you know it is 300 ml is the extracorporeal volume. So you need to know whether your patient will tolerate the 300 ml blood loss. For that, first we need to determine how much blood the patient has. So we use commonly software uses usually NATLAS formula where there are 3 parameters used: gender, height, and weight. With these parameters, it is able to get a better blood volume than the weight-based formulas. So the other easy method what we commonly use is weight-based formulas. For neonates, it is 100 ml per kilogram. For infants and small children, it is 80 ml per kilogram. And for older children and adults, we use 70 ml per kilogram. The problem with the weight-based system is it tries to overestimate the blood volume if someone is obese, and if it underestimates if someone is lean or muscular. That is the problem with the weight-based formula. That's why we always add a gender component to it in the software version. But the problem with the software version is software versions do not estimate blood volume if someone is less than 25 kilograms. So it gives a check for the operator. You check the blood volume and you enter the blood volume. That is one secondary check the machine used for a less than 25 kilograms individuals. Once you identify the patient's demographics, we are going to identify the blood volume manually. So we commonly use this formula. So weight into ml per kg body weight. For example, this is a 43 kg child with a hematocrit of 20%. Okay. So the blood volume will be 73 into 43. 70 into 43. That's around 3 liters of blood. So now we need to estimate what is the red cell volume of the child. So red cell volume is multiplying the total blood volume into hematocrit. So that gives the red cell volume. So the red cell volume of the child is 600 ml. So this you keep in mind. So these are things which you are going to follow. So once you identify these two, so next is what is the percentage ECV of the child or the patient. So that is, we know the ECV of the circuit. we know the blood volume of the recipient on whom you are going to do the procedure, and you multiply them. So the extracorporeal volume of the Optia machine is 300 ml, and the blood volume of the child is 3000 ml. So the extracorporeal volume percentage extracorporeal volume of the child is 10%. So the goal is we need to limit the intravascular volume changes to less than 10 to 15% of the TBV of the patient or the donor. So in an adult setting, maximum we can change allowed is up to 15%. You should not exit beyond 15%. And in a pediatric setting, you should not exit beyond 10%. This is very important thing before you plan a stem cell collection. What is the percentage ECV of the recipient or the donor on whom you are going to do a stem cell collection? Once that is done, so we are going to decide on the vascular access. So these are all in the planning stage. So we generally prefer 2-point access because we require a fast and an uninterrupted continuous blood flow for over a period of 2 to 4 hours. So in an adult, we expect the flow rate to be somewhere around 40 to 60 ml per minute. So the flow should be good. Only then the interface position will be proper. If the flow is interrupted, the interface will not happen and you may not get your adequate yield. Your collection efficiency, that is the amount of stem cells you collect at the end of the procedure, will come down if the flow is not good. If some centers they started like they avoid central venous access for adults, they use the peripheral venous. If you're using peripheral line directly, so in a draw line, we prefer an 18 gauge needle or a larger, that is 18 or lower, and a return line we require minimum of 22 gauges. So adults we prefer a cubital fossa, like veins in the cubital fossa. So at our center, even for adults, we use a femoral access. So because flow, the problem with the venous access is peripheral vein access is limitation or mobility. So if a donor has to retain both these arms for 3 to 4 hours, it's very challenging. So that's why we prefer femoral access at our center. So some centers they practice ultrasound guided femoral, like peripheral venous access cannulation. So that is also being practiced in some other centers. For pediatrics, it's always better to have a femoral line access, and the catheter size has been given in textbooks. So I'm not discussing that. Then we need to discuss on the anticoagulation. What anticoagulation are you going to choose on these patients? So normally, citrate is the preferred anticoagulant because it minimizes activation of cellular and other plasma components. So we given a ratio of 1:10 to 1:15. The advantage of citrate is it is metabolized rapidly and there is no systemic anticoagulation. It's always a local anticoagulation. But the problem in children is, or a low blood volume individual is, the liver has a lower hepatic metabolism capacity of citrate. So the pediatric children, they end up in having more citrate toxicity than adults, the same amount of blood volume processed. So during the procedure, it is our responsibility to monitor the ionistic calcium levels and ensure the ionistic calcium levels are beyond 1.1 millimoles during the procedure. So it's always better to give a supplement as a calcium prophylaxis. It can be either given as a bolus or it can be given as a continuous infusion. So majority of the centers they started giving continuous infusion. In a study, what they did was they dilute the calcium. They use a calcium gluconate, undiluted calcium gluconate, or 3 to 7 ml per hour in a infusion pump, slowly. That is one method of doing it. At our center, what we do is we take 2 ampules of calcium gluconate, we dilute in 100 or 200 ml normal saline, then we give it 1 to 1.5 times the inlet flow rate. For example, inlet flow rate is 50 ml per minute. 50 ml per minute. We give calcium infusion as 50 ml per hour. So that is 1 ml per minute. Okay. So the hour is converted to minutes for us to estimate a diluted calcium gluconate. So we are all aware with the citrate complications. So we know the complication, like initially, as the citrate level increases, our ionistic calcium level decreases, and the symptoms of hypocalcemia will start manifesting at 30 minutes. So the symptoms will be minimal in the initial 30 minutes because of the compensatory rise in parrot hormone. But beyond that, beyond 30 minutes, the patient is going to have increased symptoms of hypocalcemia as the citrate level increases. So this is the wide range of hypocalcemic symptoms. So the ionistic calcium should be ensured it should be more than 1.1 millimoles. So how citrate these are the symptoms which are usually seen in adults. In pediatric setting, the hypocalcemic symptoms are usually presenting with vomiting or abdominal pain. Okay, you should remember that also when you do a pediatric setting. So to avoid citrate complications in pediatrics, the center started adopting less citrate toxicity. So they started using heparin. So heparin along with citrate. So what they did was they give a bolus heparin at a 50 units per kilogram after 1 hour of bolus. they start infusing 10 units per kilogram every 30 minutes. And they monitor APTT and they maintain the APTT level at 2 to 3 times the baseline. And they give citrate in that ratio of 20:1 to 30:1. So the citrate toxicity is reduced. The only thing is you are adding a heparin to it. The other alternate method is add heparin directly to the ACD like bottle. So like for example, 5,000 units in 500 ml of ACD, then start giving ACD like citrate at a rate of 30:1 whole blood ratio. The problem with the heparin is there is a systemic anticoagulation and you need to have a serial monitoring of APTT at 1 hourly interval or 30 minutes interval. So that is one thing. So we need to use, because we don't follow this one, but there are centers in India, they use routinely heparin also. Then coming to low blood volume individuals, low blood weight individuals are always associated with the low blood volume. So in a child who weighs less than 20 to 25 kgs, the extracorporeal volume of the circuit will be beyond 10 to 15%. So in such individuals, anyone who has a lesser blood volume, so they should have a minimum hemoglobin of at least 12 grams before you start the procedure. If the 12 grams is not there, transfuse prior to apheresis, then start the procedure. And if someone is having a severe thrombocytopenia at the start of procedure, always transfuse platelet count to keep it above 40,000 so that they don't have the bleeding complications. This is one common scenario we face. Okay, there's another way around. If someone has a high hemoglobin level, so that is also a problem. If someone has a high hemoglobin level beyond 18 grams who is eligible to donate stem cells, 18 grams machine will not recognize your layers. It's very difficult to collect stem cells. So in such individuals, what we have to do is we need to do a therapeutic phlebotomy 2 to 3 days prior in that individual, then bring the hemoglobin lower, then start the collection. That is the next method of doing. So priming, RBC priming. So prevent it like someone who is low blood volume. So RBC priming is indicated. It prevents the intra-procedural hematocrit and prevents a large intravascular volume shifts. So general recommendation is if someone's extracorporeal volume is more than 15% of the total blood weight, about blood volume, or if the patient's body weight is less than 25 kgs, we generally advise priming. Priming is also indicated in patients with impaired oxygenation of tissues, severe anemia, hemodynamic instability, or cardiopulmonary disease with a hypoxia. So this is how custom priming is done. So in the inlet line, we connect the blood bag. In the outlet line, we connect the transfer bag. So the blood is primed through the circuit before we connect to the patient. So the circuit is primed with the blood. So the extracorporeal volume is compensated with the transfused like donor unit. So in inlet in a pediatric setting, the blood flow rates we should always prefer low flow rates like 10 to 20 ml per minute in a pediatric setting, and gradually increase the flow rate 5 to 10 ml slowly. So if you increase a high flow rate, there's a high chance that they may end up in a citrate toxicity. In obese individual, the challenge is estimating the dose. So we all know we need 5 million or 10 million. So that is recipient's body weight. In an obese individual, it is very difficult to get a 5 million dose. Someone is 120 kgs or 140 kgs, it's very difficult to get 5 million cells per kilogram body. So in such individuals, so we can use an ideal body weight as a phenomenon. Ideal body weight is based on nutritional anthropometry. It estimates the lean body weight. So ideal body weight is actually 20 to 30% lower than the actual body weight. So it actually ideal body weight prevents overestimation of TBV and it correlates well with the engraftment also. So in an NMDP, what they observed is by adopting an ideal body weight, 16% of the patients had one apheresis lesser when compared to adopting an actual body weight. If someone is 100 kgs, they may end up in having 2 apheresis. In such individuals, if you use an ideal body weight as a calculation, you may require only 1 apheresis. So that is what they have observed. Like there was a presentation in TransmedCon where the recipient was 160 kilograms. So to get a 5 million, it is practically not possible in a 160 kilogram patient. So in that case, they adopted ideal body weight, whereby the ideal body weight turns out to be only 90 kgs. So they could easily get up the dose. So the thrombocytopenia. So these are all weak recommendations. In an allogenic setting, post-apheresis platelet count should be ensured beyond 75,000. In an autologous setting, so pre-apheresis platelet count should never be below 30,000. So in such individuals, we need to do a transfusion. So have time? We'll finish in 2 minutes. So in spectroptia, this was commonly done. So where the whole blood is pumped through this circuit and the separation happens at this point. The separation can be observed in this one, the right hand side. So we have a skimmer dam which lifts the mononuclear cell layer and separates it from the RBC and the plasma layer. So the separation happens based on gravity as well as centrifugal force and how we manipulate the interface between the blood component layers. So we should not leave this gravity and centrifugal forces equipment related. So we don't have any say in that, but we have say in the manipulations in the interface between the component layers, which I'll quickly cover. So the actually in Optia, we use a term called collection preference. Collection preference, it controls the depth at which the cells are collected from the Buffy code. So this is the layers which are formed. When you spin in Optia, the denser elements RBCs are pushed to the periphery and the lighter elements plasma are pushed towards inside and the Buffy is in between. So collection preference is chosen at what depth you are collecting your cells. So if you're collecting a lighter element, then you need to decrease your collection preference so that you go a little darker. And if you're collecting very dark, so you need to increase your collection preference. So in thalassemia settings, so when you are doing transplant for a thalassemia patients, so most likely a haplotransplant, the donor will be a thalassemia trait. Okay, in thalassemia trait, the problem is the traits will also have a microcytic hypochromic RBCs. Because of that, the RBC size are lesser than size as well as density are lesser than the stem cells. So our stem cells will be in the RBC layer. So in such individuals, when you do a collection for thalassemia trait individuals, you should always try to collect the lower collection preference and try to collect from the RBC layer because your stem cells will be in the RBC layer, not in your mononuclear cell layer. That thing you have to remember. So then this is one important slide, just on 2 minutes. So collection preference, it controls the concentration of cells flowing through the collect port. So if some like we use low like collection preference ranges like a scale 10 to 90. 10 means more on the RBC layer and 90 means more in the plasma layer. So we use low collection preference, that is high concentration. Low collection preference means we are collecting from the supernatant. So low collection preference means we are collecting from the bottom layer. In low collection preference, when the patient has a high MNC count, we can use a low collection preference because when there's a high MNC count, you are going to have a thick Buffy layer. So when you use a low, so the amount of RBCs will be lesser in that. Whereas when someone has a low MNC count, the patient has a low MNC count, in that case, if you use a low collection preference, what happens? So there's a competition between your mononuclear cell layer and RBC layer in the low collection preference. So you end up in collecting more amount of RBCs along with the stem cells when you use a low CP for a patient who has a low mononuclear cell count. The problem is you are going to get more amount of, because the patient is having low mononuclear cell count, you try to take as many stem cells as possible. That always comes with the risk of RBC contamination. So this you should keep in mind, and when you can, it is easily acceptable in an autologous setting where there is no cryopreservation or in an ABO compatible transplant. We use high collection preference. That means we are taking from the supernatant. If a patient has a high MNC count, that is in a donor setting, allogenic donor, generally have a high MNC count. So in an ABO incompatible transplant, we want an RBC contamination to be minimal. So in that setting, we always prefer a high MNC count because the donor already has a high MNC count. We don't want the RBCs to come in. So this is how high MNC count in a high CP setting will be available. So this one is high CP in a low MNC count. This is usually done for donor lymphocyte collections. So where we don't want to end up in collecting monocyte or granulocyte, we want more of lymphocytes. They are on the superficial layer. So you take a high CP levels. So the final thing is you need to choose what you want. You want a purified product or you want a high yield product. So if you want to go for a purified product, you always set your collection preference. By default, collection preference will be set at 50. So you want a purified product, you go start your collection preference beyond 50, around 52 or 53, and try to take a purified stem cell product with a less amount of RBC contamination, which is commonly adopted in an ABO mismatched donor setting. When you have a patient who have a low MNC count and there is no risk of RBC contamination, no need for worry about RBC contamination, always go for a start with a CP with a less than 50. So you try to take as much as stem cells as possible. That always comes with the risk of RBC contamination. So we should always remember the RBC content in the product should be less than 20 ml in a major ABO incompatible transplant. Okay. So based on this, you choose your collection preference, whether purity or yield should be taken in picture. So this I will skip. So take home messages. So we need to define acceptable limits for a donor or a patient before we start an apheresis to avoid hemodynamic complications. And the flow should be ensured, it should be an uninterrupted blood flow. And continuous flow equipment should be preferred in a pediatric settings, and complications due to anticoagulation. So you should plan your prophylaxis well. So I'll stop with this, right? So thank you all. Thank you for your patience.
Good morning, Ankit sir. Can you hear me?
Morning, I can hear you.
So I have made you the co-host. You can start your screen share.
Sure. I shared the screen now. Is that visible?
Yes, sir. Your screen is visible. Please make it full screen.
Is that okay now?
Yes, sir.
Slide is moving?
Yes, sir. Moving.
Okay, great. So can I start now?
Yes, sir.
Okay. Thank you so much. First of all, thank you, Dr. Nitin, for this invitation. And my apologies, I couldn't attend this in person. But from my side, best wishes to all of you. So I will be talking about the technology which we use in immunohematology practice, some immunohematology related tests. This technique is called SPRCA, solid phase red cell adherence technology. We all understand the importance of pre-transfusion testing. In pre-transfusion testing, we do the donor and patients ABO grouping, we do antibody screening or a cross match, and whenever the cross match compatible unit available, we issue this unit to the patient, we transfuse this unit to the patient, and this testing we all do to prevent any hemolytic transfusion reaction. We can have two different kinds of protocol for pre-transfer testing. Most of the centers in India practice this protocol where we do donor sample ABO grouping and we keep this inventory with us. As soon as patient sample available, we select a ABO compatible unit, we do a ICT cross match and we issue this unit to the patients. Many centers started using a type and screen protocol in India, which is followed by most of the Western countries. In this protocol, of course, we do donors ABO typing and we keep inventory with us. But instead of doing directly for the cross match, whenever there is a patient sample available, we do antibody screen. If antibody screen is positive, we identify the antibody, and once we identify the antibody, particular antigen negative unit we need to provide to the patient. So this is called type and screen protocol of pre-transfusion testing. Whichever protocol we use for testing, there are various methods of technologies available how to process any pre-transfusion testing. The basic, the conventional test tube technique, which we all are using from long time and many years, this has been established. It's a very good method of testing. Apart from test tube method, the column agglutination technique is available, SPRCA technique is also available, and there is something called erythrocyte sedimentation technique. These are the various technologies available for pre-transfer testing. As I mentioned, the test tube technique is going on from long time, from years people are using. We all have been trained how to do a tube-based the grouping, tube-based cross-match and everything. It's a very good technique. We can do incubation, we can do centrifugation, we can do the manipulation of the testing whenever for particular case it is required. If we have to increase the cell and serum ratio, we can do. If we have to increase the temperature or decrease the temperature of incubation. All these manipulation on the basis of case of immunology case, we can do this manipulation. It's a very good technique. We get very good results from this technique or from this method of pre-transfer testing, but it has its own limitation. So limitation in the sense it's not very sensitive when you deal with the low level of any allo antibody. It gives sometimes a subjective reading. So whenever you say 4+, 3+, 2+, or the most difficult part is the V+ or a negative reaction. And the important is it cannot be done in automation. So when we collect 100 units in a day from the donors, from of the donor grouping, or you have a high, is a busy hospital getting many samples at a time, from OTs to do the cross match and all. So it's automation is not possible using a group tech, but the test tube technique. So therefore, there's a limitation of this test tube method. So this is the way we do the grading of whenever we see the results from test tube technique, 4+, 3+, 1+, negative, and we can also see microscopic reading. Another method which is popular, it's called column agglutination technique. This is also this is a sensitive method. It can be automated. It can be automated as well. In this, we have a well. We add cell and serum, and we do the incubation and centrifugation, and then we see the results like this. So the uppermost, if you see the cells are in the upper layer, it's a positive, and all the cells are settled. It's negative. So this is the sensitive technique, and we can do the automation with this technique. Coming to this technology which I am going to talk about, it's called solid phase red cell adherence test. So in this test, as you see from the name, in this test, what happens, we have a well. In this well, we immobilize or a particular load the antigen or antibody in form of a layer or in form of solid medium. And then the opposite we add, which we want to detect. If the question is either antibody, so the antibody will be added. And then finally, we have an indicator in form of either a fluorescein, enzyme, or red cell. Whenever we use indicator red cell, this is called solid phase red cell adherence assay. So similar technology is used in Luminex for accelerated testing, but for red cell, which we use SPRCA for the antibody screening, cross match, and similar test which we do in immunology. So SPRCA can do various tests, like I mentioned, the pooled cell ICT, 3-cell, platelet screening, antibody identification, and using the same the way of automation, we can do blood grouping by ABO, reverse, RH typing. So various tests can be done using this method. So this technology, which is SPRCA, it's called capture technology, which is patented by Immucor. In this technology, like I said, antibody screening is the commonest the test which is done. Identification can also be done. VD testing, DCT, extended typing, all these titrations, platelet cross-match, all these tests can be done. This is IgG specific technology, which is sensitive to detect IgG antibodies, and it can be automated with various platforms, and we can see the results directly in the machine on our computers. So in this technology, what happens, we have the cell is the antigen coated well we have. So the well is coated by some particular antigen. Suppose if we are using this technique for pooled O cell antibody screening, or you can say ICT. So we have a pooled O cells. The cells are coated, the donor cells are coated, the antigen coated wells we have. So these are we have an antigen coated well. Then we add the LIS and plasma and serum. If there is antibody present, suppose this layer has the Duffy A antibody, and this antibody is, the serum has this antibody, this will coat this antibody and form a layer. So this coating will attract the antibodies, and antibodies will go and bind to this layer. The next step is the washing. The moment we wash all the unbound antibodies which have not bind to the cell surface will be washed. So now finally what we will have in the well, we will have the antibodies which are bound to this cell layer, and this will form in form of a FS in form of a layer in this microtiter well. Next step is we add indicator red cells. So moment we add indicator red cells, what is the indicator red cells? These are the indicator red cells are attached to IgG and antibodies. So these antibody, which is antibody to antibody, will go and bind to the antibody which are already fixed to this layer. So this all these indicator cells will form a layer with the help of this anti-IgG antibody. So if it is a positive reaction, if there is antigen antibody binding happening, it will form a layer like this. And if there is no antigen antibody binding happening, all these indicator cells will form a button as a pellet at the bottom. So again, the similar thing, again, representation like this. So in this technique, what we have a well which is known, which has which has antigen coated well. The moment we add the lys and serum, this antibodies will go and bind to this layer. So antigen antibody binding will happen. We will do a washing. So unbound antibodies will be washed away. Then we add indicator cells. These indicator cells will have IgG antibody bound. So this IgG coated and IgG attached red cells will go and bind to the antibody which is already coated or bound. So therefore, if there is antigen antibody reaction happening, so the reaction will look like this. If there is no antigen antibody reaction, it will form a pellet or a button. Same thing is here. So we see the result like this in form of a positive reaction when there is a layer has been formed because of antigen antibody reaction. If there is no layer formed, all the indicator cells will form a button as a pellet at the bottom like this. Same thing as a side view, the positive reaction look like this because all these red cells will, indicator red cell will form a layer, and top view look like this. Same thing, negative as a side view look like this as a pellet or a button because there is no antigen antibody binding happen. It's a negative test. So we can also do a grading using this grading method. If there is a picture like this or like this, so grading will be there from 4+ to 0 or a negative reaction. So this we can use this grading as a comparison to other technique. If this layer is like this, is a 4+. In a heme agglutination technique or as a test tube technique, whenever we see the agglutination like this, it's a 4+ reaction. And we see in gel technique when we see the cell layer in the top, so then it is called 4+ reaction. So similarly, 3+, 2+, and negative reaction we can compare with the test tube technique and gel technique like this. So this technique is used for antibody screening, identification. We use this technique for our the donor antibody screening using cold ocell. So in antibody screening, we have 3 donor cells in form of R1, R1, R2, R2, and small r. These are the 3 cells generally used for antibody screening. So these will be coated in 3 different wells. Then we add the patient serum, and then we can see the reaction whether it is in donor cell number 1, 2, and 3, and then we can interpret it which could be the probable antibody. And identification again can be done using 11 cells or 12 cell, again using a coated wells. So this technique is automated by this system which is called a Neo-Iris machine by Immucor. And this system can also be used as a heme agglutination technique for ABO grouping as well as RH phenotyping. So in this heme agglutination or technique, or when we use this system for a microtiter plate based ABO grouping, what we have, there is an uncoated microplate. On this microplate, we add the known antisera for forward typing and known cells in form of in reverse typing, and then corresponding cells and the plasma will go in respective wells, and then we see okay in which well agglutination is happening or not. and then it's a proper microtiter based blood grouping. The protocols which can be used in this microtiter plate are different. You can have a 8-well, 6-well, or a 12-well protocol, depends on whether you want to use anti-A, B in your forward typing. You want to use two different manufacturers of RH typing like D1, D2, D2. It depends on which kind of protocol you use for your blood grouping method. And this, as a reading, as a picture, will be captured by the machine, and this machine will interpret it, the blood grouping, and then the blood grouping is transferred to your LIS or the hospital management system or information system to the software as an information. So advantage what we see in SPRCA is a very sensitive technique and compatible to automation, and we use this technique for all our donor grouping as well as antibody screening. It is less subjective for result interpretation. The results are stable. All these results are captured in the system, in the machine, which can be reviewed later as well. Small sample is required, and the reagent volume is required. There are various literature available to see, to get an overview about this technology. Many comparison has been done, many literature, many papers are available to compare this technology to other available technology, whether it is gel card, column, or test tubes. So the comparison from this study, it looked like it's a highly sensitive technique as we compare to other technique. It's 97% sensitivity in this paper, which they found. There are some papers available not only from Western countries, 1 or 2 case reports from India as well. This technique is highly sensitive to detect anti-KIT antibodies, and if it has, there are literature available, the case reports available. There are some cases that KIT antibodies missed by gel technology or column technology and has been detected by solid phase assay. So there are case reports to mention about the very low level of JKA antibody or JKB antibodies being detected by solid phase assay. And we all understand the SCID antibodies are considered one of the notorious antibodies where the level goes significantly down in the patient over a period of time, and then sometime it is at the level which is cannot be detected. So this low level antibodies is not detected, patient can have secondary immune response after transfusion. So it's important for us to find out as much as clinically significant alloantibodies possibly present in any sensitized patient. So this technology helps us in detecting KIT antibodies, which are otherwise we call the notorious antibodies and difficult to find in some sensitized, highly sensitized patients. To summarize my talk, blood safety, in any blood safety, the processes, the most important or the very important aspect of blood safety is pre-transfusion testing. Whatever test we use, whatever technology we use, it has to be, has to be validated for that particular particular method or test which we are going to use. Nowadays, we all talk about automation. The newer technologies are important because these techniques are compatible for automation. Automation is need of the hour because we want to reduce the manual interpretation as much as possible, reduce the human intervention wherever possible, to standardize any technique to get the quality results. So it should not depend on somebody's the skill or the way he does the test. So the moment we have a standardization, automation, we reduce human intervention, then we get a quality results. Whatever technique we adopt for our lab, for our IH lab, it has to be standardized with using quality control technique, quality control samples, in-house prepared or outside prepared, and we have to learn how to interpreted these results carefully. Every technology has a different way of interpretation. So training of staff, training of people is again a very important aspect of maintaining this standards or the quality standards in immunometallurgy. So with this, thank you so much, and I will be happy to take any questions. Thank you. Over to you, Nitin.
I would like to thank Dr. Ankit Mathur for providing us with his valid insights into the newer technology of SPRCA, which we from Kerala recently introduced to. So I invite Dr. Prashant Parameshwaran, Senior Consultant, Medical Oncology, MVR Cancer Center, for presenting his topic on advanced cellular therapies.
Thank you. At the outset, I thank Department of Transfusion Medicine for giving this opportunity. I think so. There may be residents, there may be consultants. So this may not be a part of transfusion medicine, but still, this is going to be the future, which all of us will be involved in the care of all the patients. So I think so. I just want to give you a flavor. You don't have to note it down anything. It is just a brief of how the medical science is going on. So before knowing cellular therapy, you should know something called field of regenerative medicine. We are hearing it from the time of MBBS times, or most probably before that. But you want to try to replace a human gene or cell or a tissue or an organ, and you want to try to cure the disease. So there have been many aspects for this regenerative medicine, out of which one of the biggest impact has been on gene therapy. We have heard that HIV can be cured, diabetes can be cured. In same way, there are many lysosomal disorders, mitochondrial disorders, which can be cured by gene therapy. With the help of this type of viral transfection, these faulty genes can be replaced. Unfortunately, it is still not a path breaking, and except some pediatric diseases where you have still got gene therapy as a standard in many of the mitochondrial and lysosomal enzyme deficiency disorders. But still, gene therapy is still on the just on the start, I feel. Two things which have made an impact. One is basically in 2012 for lipoprotein lipase deficiency. This gene therapy was approved called Glibera. And all these children who are dying within 8 years, 10 years with recurrent acute pancreatitis because of this deficiency has been cured by this gene therapy. So the future is going to be more and more gene therapies. So in next 3 years, 4 years, there are going to be 10 or more products. So gene therapy has also come into oncology. Then there is something called immunomodulation, where you're playing with your immunity. You're trying to improve your immunity against certain diseases and try to harness the harmful immunity which is producing certain diseases. That's called immunomodulation. So many of the systemic sclerosis, vasculitic disorders are due to excessive or your faulty immune system, and some are due to your immune checks are not happening correctly. So the immune modulation is being targeted in many of this. This is also a branch of regenerative medicine. Then there's something called tissue engineering. Tissue engineering, this and all are exciting areas if you start reading. There's something called 3D printing. Now, we used 3D printing recently for something called brachytherapy, for radiation. For drug delivery, there is something called 3D printing, where you have got off-shelf things which have been made, and it is suitable for each patient. You can modelize for each patient, and you can have better efficacy and control of the disease by this type called tissue engineering. I'm not going to the details of all these things. So my talk will be basically on cellular therapy. So cellular therapy is basically you transfer the autologous or allogenic cellular material to a patient for a medical purpose. So you are not using any chemicals or compounds to treat a disease. You are using his own cell for treating the disease. So broadly, it is based on a stem cell based cellular therapy or non-stem cell based cellular therapy. So the left side is a stem cell based, which you all are aware. That's our famous bone marrow transplant, which made a big impact. Non-stem cell based cellular therapy is one which is coming up in a big way. That is called the immunotherapy, T cell based therapy, NK cell based therapy, dendritic cell based therapy. So my talk will be basically on the right side of the graph. It's not on our old stem cell. It's basically on non-stem cell based cellular therapy. There are two disclaimers for this talk. One is As I'm an oncologist practicing hemato-oncology basically, my talk will be basically on oncology. But cellular therapy is there in many diseases, and I think so in future it is going to be an answer for many of the diseases probably. Second disclaimer is I don't have hands-on experience on this. I have only theoretical experience and what I have read and what I have heard from others. But let us see what will be your take-home point regarding this. So if you have a patient with cancer, these are the armamentariums you have to treat him. You have the very old age chemotherapy, surgery, radiotherapy, hormonal therapy. Then there's something called bone marrow transplant. There is a new kid on the block called immunotherapy. But still, there are many cancers which are not curable. Many means even now stage 4 cancers are only controllable. It was 4 months or 6 months. Now it is 4 years or 5 years. But still we have more miles to walk on this. So we are thinking of more and more new modalities of treatment. The new modalities of treatment has been cytokines, viruses, oncolytic viruses, cancer vaccine. Cancer vaccine has been a big topic himself. And then there is something called this cellular therapy, is called CAR T cells and adoptive cell therapy. So all these are new things which are coming up in the branch of oncology. So in this cellular therapy, they use cells itself as a medicine. That is the basic concept basically. You're using your own cells to act as a medicine. And if you look at whether you are thinking you are going to have a progress, almost there is triple the trials in the field of cellular therapy, and more approvals are happening year by year. Which cancers has proven efficacy for cellular therapy? As of now, the greenly marked leukemia, lymphomas, and myelomas, which are relapsed refractory to all the treatments, which there is no treatment, and you are telling only palliative care. Now we have got cellular therapy option. And believe me, I'll show you some graph which shows that the response are durable and pretty adorable, basically. The one in blue, metastatic melanomas and a pediatric cancer called neuroblastoma. There are almost path-breaking impact on cellular therapy. The other fields are still going on. Maybe it takes more time. It's not as easy as a hemato-oncology for having an impact. But in future, you will have in many solid tumors also, the cellular therapy impact. So in cellular therapy, one is we use the T cells. T cells are used. It can be a natural T cells which are isolated from the blood, and tumor infiltrating lymphocytes are extracted from that, and it is given back to the patient, and that goes and attack the cancer. Is the basic theory. So that is natural T cell. So we were under this natural T cell cellular therapy for this much years. That was the main reason that we didn't have a big impact on the management. But recently, you have started something called genetically engineered T cells, or something called CAR T cells. So you are taking out the patient's T cells and you are genetically engineering it in the lab, attaching it with an antibody, and then that targets the tumor associated antigen and it acts against cancer. So it's called genetically engineered. It's a little bit more of physics, basically by the scientists. So it's nothing to do with the doctors who have done this. The all credit goes to the physics and IIT scientists which have done all these things. But still. So this is what I was telling. So the first example for cellular therapy is our long-standing bone marrow transplant. Even if you think that bone marrow transplant works with chemotherapy, it's not the fact actually. It's not the chemotherapy which is acting in bone marrow transplant. Once the chemo conditioning is over and the donor T cells take over. So the donor T cell produces an immune-mediated effect. That's called graft versus leukemia effect, or GVL effect. So it is a GVL effect which is checking the cancers for preventing the relapse. So basically, this was the oldest proof of a concept that cellular therapy works. Cellular therapy works in patients. More on detail on transplant, I think so Christian will discuss in the afternoon. So I will not go to that. Then by 2013, where I told that natural T cells are being taken. So this first positive trial came with the name of something called sickle cell T. Sickle cell T was one of these tumor infiltrating lymphocytes. They were extracting from the prostate cancer patients. They were expanding it and transfusing it back. And it was approved by US FDA as one of the treatment for refractory prostate cancer, where they could live 1 year more. When they exhaust all the lines, again, they could live more. But unfortunately, I'll tell you, there was no engineering. So because of that, because of the efficacy reasons, commercial reasons, that got discontinued in 2015. And again, there was no cellular therapy for us. But then in 2018-19, there was a boom with the form of CAR T cells. And this is now the standard of care in many of the treatment cancers. It's called chimeric antigen receptor T cell engineering. CAR stands for chimeric antigen receptor. The design is basically, it has this car has got a heavy chain, light chain, and an antibody coding region. And this you can link with whichever antibody you want in a particular type of disease. So it can be tailor-made for each diseases. So what happens is that it is specific to the tumor-associated antigen. So when you have a lymphoma, which is relapsed and you have CD19 positive, so you have got a CD19 CAR, you have a CD22 CAR. So when you engineer these T cells and give the antibody or attach the antibody to the T cells, and when you give it back, it goes and find out where all the CD19 abnormal lymphocytes are there. It goes and bind to that. That's called tumor-associated antigen binding, and it helps to kill the cancer. So that is how it works. So basically, when they improved the T cell, the efficacy increased. And how they kill? The kill is basically by a normal T cell mechanism. That means granzymes, perforins, all are released, and it's something like a body's defense acting and killing it. So that is how a CAR T cell works. How do you manufacture a CAR? So the first part is basically transfusion medicine. I don't know the much details about this, but still what I understood is that my colleague is doing the first CAR T cell trial in Tata Memorial. So from this slide is basically from him. So the basic, and then the same MNC protocol we are using for patients' leukapheresis. And you are extracting the T cells or the lymphocytes. You are extracting the lymphocytes, and then that is sent to the lab. So the step 2 and 3 are the most important one. So that requires a particular lab. It is basically the basic scientists which are doing. What they're doing are 2-3 things. One is they extract the CD3 positive T cells. After that, they attach the antibody. They produce the transduction. That means the vector, either an adenovirus, lentivirus, whatever vector is attached. The expansion of T cell happens. So this usually happens in 3 to 5 weeks. You take out patient's blood, then in 3 to 5 weeks, it is sent to the lab. And then all this CAR production happens. The clonal expansion of T cell happens, and then you are infusing back to the patient. So it is basically the lab which has got the more complicated work in this group of this. So if you are asking me what is the journey of a patient, you identify the patient, you do apheresis. Apheresis can be with growth factors or without growth factors, depending upon the T cell WBC count or the MNC volume. And then you send this to the lab for CAR production and clonal expansion. Meanwhile, you can give chemotherapy because 3 to 5 weeks of gap is there to get this in between. Patients should not relapse. Then this is important. There is something called lymphodepleting chemotherapy. That means after that, we give a small, normally we use something called fludarabine. Fludarabine and a load of cyclophosphamide is used. The main aim of this lymphodepletion is basically to reduce the number of lymphocytes. So when you're infusing back, so our Tregs should not recognize that and reject it. So we want to reduce it. We have to remove the immunosuppressive elements and induce this co-stimulator molecule expression, and it helps to promote the expansion of CAR. So always, even if you don't give the chemotherapy, lymphodepleting part of chemo has to be given before giving CAR. So we lymphodeplete and then we infuse the CAR, which has come back from the lab. They cryopreserve it and they send it back, and then you have to infuse the CAR. Then around 1 month is the time where all the reactions happens. And then by 30 days, you can see the initial response, 60 days and 90 days. And there are data showing that up to 180 days, there will be an ongoing response. By this, T cells will expand in the body, and this will go and act and fight against the T cells or the tumor-associated antigens in the T cells. So it's basically a personalized therapy. It doesn't mean that each will have same CAR. You are taking your T cells, you are making a drug, and you are giving it. So it's a new branch of personalized therapy in cancer. And if you can see, the response rate in this bar graph, CAR T cells has got a pretty impressive response rate. There's a question about how much this response sustained, that will come later, but it has got a good impressive response rate. So which all are the approved CAR? We have 3 CARs now approved for lymphoma. This name is a little bit haywire. I don't know why they put this type of names. Anyway, it's called axibactagene, tisagenlecleucel, and lisobactagene. So these are the 3 CARs which have been approved. For mantle cell, we have a CAR. Multiple myeloma, we have a CAR. And acute lymphoblastic leukemia, relapse refractory, we have a CAR which is available. As of now, it is after 2 lines. But in future, it will be of 1 line, and very future, it may become a first line also in some group of patients. That is how the medical science evolves. This was, I'll just show you a few data. It may not be useful for you, but I'm telling you how much impact it has made. A person with a relapsed refractory lymphoma, the median survival is around 5 months, 5 to 6 months, if they lose 2 to 3 lines of treatment. But with this CAR, 42.6% are alive at 5 years. So that means around half are alive at 5 years. It's a big impact. This is the Suma one's comparison with the standard of care arm. So which I told 5.4 months is the standard of care median overall survival. And here the median overall survival is 31 months, which is pretty impressive. This is the Chimera. Chimera was one of the first CAR which got approved. This is called Tisagenlecel. It is by a Novartis product basically which came. And it has shown that almost same. That means 40 to 36% are alive at 3 years. So there are a big impact in this group of patients which didn't have any treatment options which is available. The problem is CAR T cells is not available in low and middle income countries. This is a world map of where all the cellular therapy trials are happening. If you see the left of the Atlantic, you can see that there are 176 trials are happening in US. The US has, when you go to right, that green one, the yellow one is Europe. Europe is around 39 trials are happening. The green one is Russia, which there is only hardly a trial. And the red one is China. So you can believe that China is having 232 trials happening. So China is going to be the next biggest impact. I think so we should follow China more than US and Europe for any of these things. Unfortunately, India doesn't have a CAR T cell trial which is happening, which is happening as of now. But I'll tell you the thing. So majority of the patients in our country choose palliative care and don't survive. So the first CAR T cell therapy in India has been developed by IIT Bombay, a scientist which was interested for last 10 to 20 years called Rahul Purwar. He came for our last conference and had a talk on this. So it was impressive, his journey. When people didn't have any look on this, he persisted. And they did the first trial. It was just completed 6 months before with around 10 patients in Tata Memorial with relapsed refractory lymphoma. A CAR, we had recently looked for a doctor's daughter with a refractory leukemia, availability of a CAR, and it was coming around 1.8 crores. So the aim of the Indian CAR is to bring it down to at least 20 to 30 lakhs, so that at least many of the Indians can afford it. But the problem is that it is complex, many variables are required, patient population, conditioning therapies to construct the CAR. CAR construction is the most important. Then how multiple centers are required and stringent regulations which Indian government has regarding the research. So it's very difficult for them also to go forward. But still, it's still a light on the boom. This was the I got from him who was doing the trial on CAR T. This one of a patient with Indian CAR. You can see the left side, the bulk of lymphoma, which is there in the abdomen. This is after 60 days of CAR T cells. This was a patient who was exposed to 5 lines and he was almost bedridden. He was almost on the verge of terminal supportive care. And the right side, you can see the response of how well it has responded. So there are enough reports to tell CAR. And now the algorithm has changed that if you have a relapsed refractory lymphoma in Western countries, CAR T cells come even in the first line or second line. You don't have to wait for 4 lines and 5 lines like that. So the algorithm is going to change very early. In solid tumors, it has not become an impact. I told in melanoma, there have been some path breaking, but other solid tumors, it has not become so impactful. There are many reasons, because you have to find the tumor. It's not like a circulating tumor cells are so evident like a hematological cancer. Then you have to infiltrate into the tumor and survive in the tumor. So the mechanism is more little complex. They're trying to find out, but there are this much CARs being tried in all these cancers. I think so in near future, you will have CAR. This is an example of a melanoma, which I got when I was doing my literature review. So you can see that the mediastinal nodes has regressed well in a heavily pretreated melanoma with 22% complete response with the cellular therapy. Nothing comes without toxicity. There is a peculiar toxicity called cellular therapy associated toxicity, which are coming. It's called the on-target and off-target toxicity. So you can have a cytokine release syndrome, from a small cytokine release syndrome to a life-threatening neurotoxicity, which are reported in enough trials. And so stringent monitoring is required. And the future is going to be, you are having 4th and 5th generation. India has not yet reached the 1st generation CAR. the Western countries has reached to 4th generation CAR where you are having a bispecific antibodies, which you can, I told initially, you can bind the CD19 or CD22. Now they are producing bispecific antibodies, 2 different type of antibodies you can bind with one CAR. So the efficacy is going to be more better. Then you have autologous to an allogenic CAR. That means now you have to take out the patient's blood, you have to construct something and you have to give back. So there is some gap. So if you can have an allogenic CAR where you can re-engineer the T cells from any donor and you can make off-the-shelf CAR. They call it off-the-shelf CAR. That means you come, you tell you have a relapsed refractory lymphoma, you take out from this pharmacy that this is the CAR for you, go and take it. So it's going to be like that. Then there's something called NK cells. Natural killer cells is more complex than T cells, but it just considered to be more line of defense or preventing the relapse in leukemias and lymphomas. So NK CAR is going to be offered in the near future. Then there are something called mRNAs which are being tried in the type of cellular therapies. So to summarize, I'll stop here. Cellular therapy is on a boom. It's high time to invest on this. High time to invest means trials, not only on trials, if you're on stock market, start investing on cellular therapies. I feel that all these companies are going to do well. Even the startups from India, they will do well. The role of transfusion medicine will increase because I feel there will be something called Department of Blood Transfusion will be changed to stem cell therapy or more cell therapeutics. And you will have more and more recognitions and more regulatory approvals will be more stringent and will be under somebody because you're using a person's human cells for all transportation and all purposes. Somebody will have to take the lead. And I feel that there will be a big impact on the field of transfusion medicine also with the growth of cellular therapy. I'll stop here. Thank you.
I would like to thank Dr. Prashant Parmeshan for his wonderful and insightful talk on adoptive immunotherapy, especially CAR T cell therapy, and the wonderful future that holds for each one of us. So we have decided to add the faculty along with the group which we had formed for the participants in WhatsApp, so that if there is any questions by any of you, you can ask them personally in the group. And after this, we will go for tea, and after that, we'll go directly to the demonstration sessions in the department at 10:30.
This will be the flow of my presentation. So first of all, what is hematopoietic stem cell transplant? Is it stem cell transplant or hematopoietic cell transplant? So the graft contains a lot of cells like T cells, stem cells, B cells, osteoclasts, and everything. And many of them are useful. So, and second thing, transplant is used nowadays for a lot of other indications than blood disorders like storage disorders and all. So now it is called hematopoietic cell transplant. It's no longer stem cell transplant. Next is it hematology, oncology, or immunology? So this is very important because as far as hematology and oncology is concerned, transplant doesn't have much to do other than managing the febrile neutropenia and transfusion support. The bone marrow transplant or hematopoietic cell transplant is pure allogenic immunology only. So it is the T cells which play a very, very important role in transplant, and they decide the outcome of transplant in a lot of ways, which we'll discuss about it in some time. So the differences we need to know about a hematopoietic cell transplant and a solid organ transplant. So here in a hematopoietic cell transplant, we are putting a lot of immunocompetent cells in an extremely immunodepleted host. Whereas in a solid organ transplant, we will just be putting a normal organ in a host who is immunocompetent. So the thing which happens is the immune system which we put learns over a period of time what is normal for the host and adapts to it. So we don't need immunosuppression lifelong. We can stop immunosuppression at 3 or 4 or maximum 6 months. Whereas in a solid organ transplant, we cannot get away with that. We will have to probably give some lifelong immunosuppression for most patients. So that is the basic difference between hematopoietic cell transplant and a solid organ transplant. So history, so everything started with the use of atomic bomb and nuclear research, where people started getting radiation-induced aplasia. So people really wanted a cure for that. So that's why people started thinking about, is it possible to transplant the bone marrow from somebody? So in 1956, Barnes and his colleagues first did transplant in a group of mice. So what happened was, they had a group of mice with leukemia. They gave TBI radiation for both. They divided into two groups, gave radiation to both groups, gave a stem cells to one group and did not give stem cells to the other group. So the other group relapsed with the leukemia, whereas the group which got stem cells did not relapse with leukemia, but they had died of something called GVHD, something called wasting disease, which they did not know it was GVHD. So they proved 2 or 3 things there. One, it is possible to do a transplant with TBI based conditioning. Second, some sort of conditioning is needed. And third, they had found out that there is something called graft versus leukemia effect, which helps in getting rid of the leukemia in these mice. Okay, so the first human transplant was done by Dr. E.D. Thomas in 1957. And by around 1960s, they had started identifying HLA typing and HLA alleles. And then we had the evolution of conditioning. So initially it was all TBI based, and then we have now around reduced intensity conditioning. And nowadays we have high resolution HLA typing, we have unrelated and both haploidentical, and lot of other kinds of transplants. So first, let us see what is HLA. So they are a class of antigens which are mainly coded in the short arm of chromosome 6 in the major histocompatibility complex. So there are 2 groups of HLA antigens, class 1 and class 2. So the class 1 consists of 3 pairs, A, B, and C. These are present in all nucleated cells. These are generally recognized by CD8 subgroup of T cells, whereas class 2 consists of again 3 pairs, DR, DQ, and DP. Currently, we don't consider DP of much importance now, but in the future, maybe it may be important. But it is mainly present in antigen presenting cells like B cells, macrophage, and dendritic cells, and it is mainly recognized by CD4 type of T cells. So these are extremely polymorphic genes. Like there are about 100 or 200 different alleles for each of the HLA genes. Like A will have 100 or 200, B will have 100 or 200. So it is extremely rare for somebody to have a 10 by 10 match with somebody who is not related. But there are matches. It's not uncommon. So, and then these are the major HLA groups, and there are multiple minor HLA antigens which we do not know about fully, and they have a small role in some small amount of graft versus host disease. So this is a generally HLA typing report. So this is how we read it. So here, so what is this 11.01.01? This is a high resolution HLA typing. So if you have a low resolution HLA typing, it will be just 11, nothing more than that. Anything more than that is called high resolution. So the first 2 numbers, 11 is called the antigen, 01 is called the allele. It is not the allele which we talked about 200 or 300. This is called an allele. Okay, so this is called antigen and this is called the allele. So if it is numbered like this just for convenience. So if it is like 11.01, 11.02 is a different HLA type. It is not the same. So it is same in the antigen, but it is not same in the allele level. So you might get away with some amount of GVHD, but you might get away. It could be possible to transplant, whereas 11.01 and 12.01 are not same. You can't do that. So similarity in the first antigen level is okay, but not in the allele level. So the donor types. So here, the donor types basically in the peripheral blood or the bone marrow grafts are, we can have 3 types of donors. One is a 10 by 10 donor, and 10 by 10 donors can be either from the matched family or a matched sibling, which is possible in about 25% of patients. Say like if one person has a sibling, he is 25% chance of being 10 by 10 match, or if somebody has some 4 siblings, there will be definitely one who is going to be 100% match for him. If we don't have a 10 by 10 match, we search for an unrelated donor, 10 by 10 unrelated donor in many of the registries we have. Any donor who is not 10 by 10, like 9 by 10, they are called mismatched donors. So it can be a mismatched family or a mismatched unrelated donor also. And anything less than that, 5 by 10 to 8 by 10 is called haploidentical donor. So the reason the donors are chosen like this are the complications with transplant increase the way once we go from left to right. So next, the graft type. So there are basically 3 types of graft. One is a peripheral blood stem cells. Next is a bone marrow graft. Third is an umbilical cord graft. So the pros and cons are the peripheral blood stem cells are very easy to obtain. We just need to do an apheresis, which you would have seen in the morning, which would have had them in the morning. They have a very fast engraftment. Third, the hematocrit in those peripheral blood stem cells is very less. So you can get away with a blood group mismatch. But the problem is there is a slight increased risk of GVHD. Whereas with a bone marrow graft, that risk of GVHD is less. But the issues are the patient needs anesthesia. The chances of contamination are more, because if with a PBSC collection, it is going to be a closed system. Here it is not going to be a closed system. It is going to be an open system, and it needs an RBC separation if there is a blood group mismatch, and the engraftment is slightly delayed by about a week. And the next type of graft, which we very rarely use in India, is an umbilical cord graft. The disadvantages are mainly it has a very delayed engraftment. Means engraftment, we'll look about what is engraftment in some time. There is a very high risk of viral reactivation. The supportive care needed is very high, and the grafts are generally very costly. And the advantages are there is no chronic GVHD. That is very big advantage. And generally nowadays they are used in very refractory malignancies only. Even in other indications, people are generally not using it even in abroad. So this is how generally PBSC apheresis is done. So now the mechanism and process. So the transplant process happens in these steps. Like initially there is conditioning, then graft infusement, engraftment, then some acute complications. Then there is something called thymopoiesis and long-term complications. So we'll be seeing in detail about it in some time. So this is basically the graft composition. So graft contains a lot of cells. Even if we try to take a PBSC with selecting stem cells, CD34 stem cells only, it will contain a lot of contamination with B cells, T cells, both naive and effector cells, and other components like RBCs, platelets, neutrophils, and other cells. So there are 2 things which are very important in this. One, hematopoietic stem cells, which we call as CD34 cells. Another is T cells, both naive and effector T cells. So what they do is the hematopoietic stem cells, they engraft. So they go there, start growing. They produce both myeloid and lymphoid progenitors. These myeloid progenitors give rise to your neutrophils, monocytes, RBCs, and platelets. This part of it happens anywhere between 2 to 4 weeks. For 2 weeks for neutrophils and 4 weeks for RBCs, and around 2.5 to 3 weeks for platelets. And the lymphoid progenitors give rise to B and T cells. So these are naive T cells which are basically originated from the donor. So what they do is they undergo thymopoiesis. So what they mean, that means that they go to the recipient's thymus, learn what is self and what is foreign, and then at one point of time they become like the recipient's own cells, immune system. So that is the point where we have thymopoiesis, what's called thymopoiesis, and that is the point where we can withdraw all immunosuppression in transplants. So this is called immune reconstitution, and after this you can call the transplant success. So, and this takes place anywhere between 6 months in children to around 9 to 12 months in adults. So in the meantime, there will be literally no lymphocytes if they are not there. So that job is taken care of by the lymphocytes which go in with the graft. So these lymphocytes are very important. So these stem cells are very benign cells where they will engraft and do their job if you give them the environment, and that environment is given by your T cells. Means if the graft is weak, if I say the graft is weak, means my T cells are not there or the number of T cells are limited, I have a very strong chance of rejection. These give the graft a strength of it, but then they are not very good also. They cause side effects like graft versus host disease and all. So we have to maintain a balance between them. So their main job is to give some antiviral immunity, and they help a lot in engraftment. They give GVHD, they cause side effects like GVHD, and to some extent they cause graft versus leukemia effect, which helps us in malignant transplants. Okay, so the next thing is conditioning. So when we take a patient for transplant, his marrow is going to be almost normal, be it a malignancy or a non-malignancy. So we need to create space. So that is basically what is done with conditioning. So there are three parts of conditioning: immunoablation, myeloablation, and eradication of malignancy. So the myeloablation and eradication of malignancy, part of it is almost the same. It is mainly to create the space for the graft. So it is done with chemotherapy or total body irradiation, and many chemotherapy agents like busulfan, melphalan, triosulfan, etc. can be used for these. Next is immunoablation. So this is mainly targeted at the lymphocytes. This prevents rejection. So it is done with the help of serotherapy called anti-thymocyte globulin or monoclonal antibodies like alemtuzumab. Certain chemotherapies like cyclophosphamide, fludarabine can be helpful, and TBI is very helpful in clearing lymphocytes. So if you ask me which is more important, myeloablation or immunoablation, immunoablation is more important, because as the transplant has evolved, we will see that people have started doing reduced intensity conditioning, where in patients who will not be able to tolerate full myeloablation. So in those reduced intensity conditioning, they are very heavy on immunoablation and not much on myeloablation. So they do just the immunoablation and make the T cells which go with the graft to create that space for the graft. So that is the importance of T cells in transplant. So these are the types of conditionings. Generally, these are, let us see what is myeloablative and reduced intensity. So it is defined as, if you give a myeloablative conditioning to somebody, his bone marrow should not recover for at least 3 months if you don't give the graft. If you give a reduced intensity conditioning, normally the recovery happens in 6 to 8 weeks if you don't give the graft. So the conditionings which we generally use are like extended myeloablative or myeloablative to non-myeloablative conditioning in the reduced order of decreased intensity. So the conditioning, what to use in what patient, depends on a lot of factors, like what is the disease we are treating, who is the donor, what is the patient's general condition. It cannot be one size which fits all for everybody. So we have to put all together and then decide if we need a myeloablation or a reduced intensity or somewhere in between. So next, so we have given the conditioning, we have given the graft. So what happens next? So next is the engraftment, what we call when these start working. So initially, as we saw, the myeloid engraftment takes place. You have engraftment with neutrophils, platelets, and RBCs. It takes place anywhere between 2 to 5 weeks, depending on the graft source. Like if you have a peripheral blood stem cell graft, you will have starting of neutrophil recovery at around 2 weeks. With a bone marrow graft, it will be around 3 weeks, and with a umbilical cord graft, it will be around 4 weeks. Platelets around 2.5 to 3 weeks, and RBCs around 1 month. It will be pushed 1 week later in these other types of grafts. So this occurs at around 2 to 5 weeks, and around this period, the patient will be extremely neutropenic. So you are going to have complications of neutropenia like mucositis, bacterial infections, mainly gram-negative, fungal infections, and there is something called engraftment syndrome, which is something like your trolley due to the neutrophils damaging the lungs and the other organs. So this is a very rare complication, but can occur around this time. Next will be the acute complications like acute graft versus host disease, sinusoidal obstruction syndrome, and some amount of viral reactivations like CMV, ABV, etc., and generally gram-positive infections at this stage. So this is around the stage where, if we don't have many acute complications or not much, this is the stage where the patient is fit to go home, and then he's kept on follow-up, close follow-up. So then after this we have late complications like acute and chronic GVHD. So GVHD, anything below 100 days, before 100 days we call it acute, more than 100 days we call it chronic. And this will be the time around where we get opportunistic infections like TCP or viral reactivations. They will be at a high risk of these infections till they have this thymopoiesis to around 6 to 9 months. So maybe at a month or 1.5 months, this patient who is going to be discharged, he will be worse than a full-blown AIDS patient as compared to his lymphocyte count. If you see his lymphocyte subsets, it will be hardly like 20, 30 CD4s and 50, 60 CD8s. So they will be at a high risk of viral reactivations like CMV, adeno, and EBV. So they need very close monitoring. And next, at around 6 to 9 months, this will be the time when your thymopoiesis, which we saw earlier, happens. And it starts a bit late in adults because the thymus is smaller and less functioning. And generally around 1 year, the immune reconstitution fully occurs, and we are able to stop all prophylactic medications, and then we start all vaccinations again, because this is a new immune system. They will And then there are long-term toxicities like chemotherapy related, like infertility or secondary malignancies or TBI related, all these. So next we'll see some of the indications. So these will be mainly pediatric indications as I'm a pediatrician. So in malignancy, in like CR1, we have high risk AMLs, intermediate risk AMLs with delayed MRD clearance, or a CML in blast crisis, or a BRT ALLs who have delayed MRD clearance, a JMML or an MDS. In CR2 or further complete remissions, any AML with a relapse or early relapse BALLs or relapsed ALLs or any relapse of a pH positive ALL. So generally in malignancies, myeloablative conditioning is preferred, especially in children. There is good data in adults with some amount of reduced conditioning in AMLs because of the decreased tolerability of this full-blown conditioning in adults and older patients. And generally the outcome varies between 50 to 70% of cure. And it depends on both the eradication of the disease due to conditioning as well as the graft versus leukemia effect. It can be used in a lot of other hematological disorders like thalassemia. It is the only curative option currently, and excellent outcomes are excellent, like around 90 to 95% in sibling transplants and 80 to 90% unrelated, and with around 60 to 70% in a haploidentical transplant. And generally in thalassemia, myeloablative conditioning is preferred, and it can be used in sickle, especially if the patient has any stroke or increased transcranial Doppler or severe crisis and recurrent severe crisis. And in thalassemia and chelation, and they can live a normal life. But in sickle, this is the only way to cure the patient. And it can be used in severe transfusion-dependent hemolytic anemias, in bone marrow failure syndromes like Fanconi, dyskeratosis congenita, any acquired aplastic anemias, storage disorders like adenoleukodystrophy, Krabbe's disease, metachromatic leukodystrophy, etc. And next group of disorders where it is very useful is primary immunodeficiency. This is a very expanding field, and this is a very challenging field because the patient is very young. Second, the patient comes in with a lot of comorbidities and end organ damages. And so the transplant becomes very challenging because they will not tolerate any kind of conditioning much. So main indications are any combined immunodeficiencies. Anywhere the T cell is deficient, they need a transplant. They can't live normal life. Like any severe combined immunodeficiencies where the transplant is very urgent, and any combined or T cell defects, X-linked hyper-IgM, hyper-IgE or CARD11, Viscott-Aldrich, or in a summary, any T cell defect or deficiency needs a transplant. Disorders of immunodysregulation like familial HLH, celiac Higashi, Griscelli's, or increased susceptibility to EBV like XLP, etc., or immune dysregulation syndromes which come with autoimmunities like LRBA, CTLA4. These are mostly CVIDs which we see in older children and adults, and any immune dysregulation like severe IBD which is not responding to conventional therapy, etc., can be offered transplant. And phagocytic defects like CGD or congenital neutropenias, like, and there are now a group of disorders called Mendelian susceptibility to mycobacterial diseases. They can be transplanted. And with disorders of humoral immunity like B cell defects, it is still an open house whether we need to transplant or not. We still don't have good enough data for that. So next we'll be seeing is autologous transplant. So what is it? Is just high dose chemotherapy and we give a stem cell rescue. So what we do here is we take autologous stem cells, cryopreserve from the same patient, cryopreserve it, give a supratherapeutic dose of chemotherapy. So what this does is this kills all the quiescent cancer cells which will not be taken care of by the normal chemotherapy. And then the side effect of it is bone marrow aplasia, which is rescued with your graft which is given, cryopreserved graft which we have given. So this is what we discussed, and the main use of it is only in very chemosensitive tumors. If a tumor is chemorefractory or you don't have a complete remission before going into transplant, an autologous transplant doesn't much help. So advantages here are there is no risk of GVHD, the toxicity is lesser, and immunosuppression is lesser. So like the risk of viral infectivations, etc., are much lesser than in an allogenic transplant. The disadvantages are there is no much GVL, and it is not useful if the disease is in remission. So some indications in pediatrics are high-risk neuroblastoma, relapsed refractory Hodgkin's, relapsed refractory germ cells, medulloblastomas relapse and a retinoblastoma with CNS relapse or CNS involvement. Adults also, the indications are almost the same. The only thing, the indications for autologous are more, and they will have a lot of myeloma patients, multiple myeloma, whom the autologous is more indicated, and the number of benign indications in adults are lesser. It will be more of malignant indications for allogenic. That's it. You can take any questions.
Will be given in the group which you are also added.
Okay.
So we thank Dr. V.P. Krishnan for his wonderful presentation on the introduction to PMT. The next presentation will be by myself on additional components. So the topic I'm going to present today is a time-tested topic, additional blood components and apheresis. As transfusion medicine specialists, you will all be well aware of this particular topic. But I'll try to focus on a few points which are important to us as of now, especially in Kerala. Why have I selected this topic? Only very few centers in Kerala issue additional blood components. Fewer centers in Kerala are licensed for the same. Not all teaching institutes or even self-proclaimed RBTCs has the same. Illegal services are being practiced by a lot of blood centers knowingly or unknowingly, either forcefully or through ignorance, by giving out or issuing additional blood components without a license. It's a process of value unlocking for each and every blood bank. So rather than just preparing and issuing the routine PRBCs, FFPs, and cryos, when we add these new products into our system, it's actually it increases our revenue and it can add on to our profits. So it differentiates committed blood bankers from the rest of the lot. So actually, it's a massive differentiation from the routine practices as if being practiced right now. So it will make the serious blood bankers different in their work. It creates a mode for each and every particular blood bank who try to issue it, and it strengthens the attempt of centralization. So I would like to bring into your notice two facts that has happened to us recently to our specialty. One is a Gazette of India, and one is a good news, and another is a bad news. So the first I will take on with the good news, and that is the Gazette of India, March 11, 2020, has specifically mentioned these products. So from now on, slowly we will all have to have specific licenses for these components, and slowly the system will start serious on this and start picking up for issuing and not issuing these. So certain these are all under considerations, and even the drug controller doesn't have a specific idea regarding all this particular product. Earlier they used to give specific license for cryoplasma, but recently when I applied for it, they said it is not required. That's why I have mentioned a query on it. So all the other components are actually specific license are supposed to be given. So what's actually required for this license? For each components, we require a standard operating procedure, equipments, and consumables specifically mentioned. QC specifications, SOPs, registers, required approvals, technical expertise, and presence of mind for the consultant when we face the inspector. So in most of these components, even the drug controller, as I have already said, is new to this particular field. They won't be having a good idea, so they'll be seeing it for the first time. We are applying for this, but the law says it can be given. So it is up to us to convince them. If we are not being able to convince the drug controller, it will be rejected. That's all. So the specifications which I will be mentioning in my presentation today will be leucofiltration, irradiation, washing, aliquoting, cooling, reconstitution, AFS. So leucofiltration, these points you will all be knowing. A specific license is required. 4 micron filter is used. 3 to 4 log reduction is achieved for RBCs and WSDPs. 5 to 10⁶ WBCs per bag is required. Reduction is required for RDPs. 8.3 into 10 to the power of 5 WBCs per bag. 85% of the original component has to be recovered after the filtration. Done to prevent FNHTR, SLA, aluminization, and CME. And QC is the challenge in practicing this particular component or preparing and issuing it as of now. There is no much other complications. You get the filter, you can filter, but preparing the QC. When the drug controller comes, if you don't have a process of doing the QC, it will be rejected. So decision to be made by the blood center is which component has to be filtered, whether it should be the whole blood red cell, when it is done, pre-storage or post-storage, on demand or bedside. So each center has to have their own decision on this. For our center, we prefer pre-storage, and if the blood bank has to have its importance, we will have to have pre-storage. Even the standard says that it is better. How many components to be filtered? It can be either universal or selective. As of now, in our situation, it should be selective. Selection of bags, it can be either be inline filter or additional bag that can be attached. We use both with the sterile connecting device and inline. We prefer penta bags, inline bags, but mostly sometimes we'll have to end up based on the requirement, we'll have to add the additional bag. So I will focus on the challenges. So this the QC is the main challenge. It is either manual counting or automated counting. The routine cell counter is not preferred. Manual counting using a Nigot chamber, automated counting by flow cytometry. Manual is subjective, automated is objective, and it is more sensitive. Both requires technical expertise, but the technical expertise for manual counting is easier to obtain. Effectiveness, manual counting is simple and cost effective. Even though we have a flow cytometer in our central lab, we prefer doing manual counting due to the cost. So that's what we are following. We have an Nigot chamber. It was very difficult to obtain a Nigot chamber. We had to search for it a long time to get one, but we managed to get one, and we started doing the QC, and that's why the drug controller has approved our request. Next is irradiation. So indications are to prevent TAGVHD. It is used in immunocompromised intrauterine transfusions. SLMS donors or first degree relative donors. Pathophysiology, I'm not going deep into it. You will all be knowing that. At least 25 gray should be given at the center, 15 gray at the periphery minimum. Both gamma and X-rays can be used for it. When it is gamma rays, it should be cesium-137 or cobalt-90 using a gamma irradiation chamber. When it's X-rays, it can be linear accelerator. That's what we are using over here, but it has its own challenges. So the QC has to be done with each lot that is being irradiated using a radiochromic film. Biannual verification or annual verification of the particular equipment has to be done. That is a Parker approval that has to be done repeatedly. And expiry of RBCs is 28 days. Plated is not it doesn't vary because the plateds anyway will only store for 5 days. So the challenges faced in Kerala currently, when we went for the license, and what I have heard from my colleagues are that a lot of centers are actually now issuing without license, but it's against the law. There is a very high investment for gamma irradiation chamber specifically for blood bags. But when we use linear accelerator, this is the problem which arises. The linear accelerator, the BARC approval says that it can only be used for patient treatment purposes. But the inspector was who visited 2-3 centers in Kerala who were persistent that they wanted a BARC approval saying that blood bag radiation purposes is allowed in that particular linear accelerator. But the BARC doesn't provide that. Only a gamma irradiation chamber gets that particular approval from the BARC. So these are two conflicting ideas between two separate departments in the government, which we'll have to find a way through. So SOPs has to be there. MOUs and transportation SOPs has to be there if your products are being radiated at another sender. So you'll have to have an MOU with that particular sender. The transportation, how it is being transported, that also has to be provided. Quality control has to be well maintained, and indicators with each batch has to be provided. Personal training, details and equipment maintenance of the irradiator has to be provided. SOP requirement, each SOP should contain a description of the machine, including the source, highest and the lowest dose, number of bags to be irradiated at a time, time period of giving one particular dose, description of monitoring each irradiation using thermometers and dosimeter, validation, whether how it is done initially, biannually, and after repairs, description of the phantom, and record of validation. So this linear acceleration accelerator requires phantoms, and these components are kept in the phantoms before a radiator. So each phantom has to be validated individually, and each validation report has to be generated. So next is frozen cells, which we are not doing over here, and we haven't felt the need for it. So for completion sake, I'm saying I'm presenting 10 years or more. This can be stored up to at a temperature less than 65 degrees Celsius. 40% glycerol is used for it. Glycerol is used as a cryoprotectant. It is used for storing rare blood groups and impractical, and it's impractical unless in large centers. Polyolefin bags are used for storage because the routine bags will be less, more brittle. And deglyceration has to be done after the storage is completed, and it is done by washing with 3 separate washing with saline solution at 12%, 1.6%, and 0.9% concentration. Again, washing. We have a specific license for this, both for PRPCs and platelets. So it is done by saline, either automated or manual washing can be done. It is usually done for allergic reaction post-transfusion in IgA deficiency. Removal of antibodies against patients' antigens, especially in NATE, HDN, alloantibodies, ABO antibodies. Removal of substances like potassium and mannitol for neonates, preterm babies. Washing can be done 3 to 5 times, and PRPCs can be stored for around 2 to 6, 24 hours for 2 to 6 degrees Celsius, and platelets for at room temperature for 4 hours. So the challenges we are facing is that a lot of clinicians ask for wash PRPCs for a lot of indication that is not required to be done, which we have to reject when we come across. So there's a common problem. Special licensing is required, and QC is not specified. So we will have to have a convincing QC for ourselves. We have created one, and they accept it. So aliquoting, neonates and children who doesn't require a full dose has to be aliquoted. Packs or sterile connecting devices can be used for that. Plasma shall be aliquoted before freezing, because once stored, it shouldn't be refreezed. It carries the expiry of the mother pack. That's very important. It reduces the donor exposure and improves the inventory management, this aliquoting. Volume of the mother pack has to match the standards if issued for a particular patient. If you are aliquoting a part of it and issuing the rest of the mother pack to another patient, the minimum volume has to be matched to the standards. The platelets, if aliquoted, shall be transfused as early as possible if the bag is not supposed to be stored to store platelets. So if you are using a usual transfer bag for a platelet, you have to you shouldn't store it for a long time, because of the air mobilization is not happening. Again, the challenges is specific licensing and QC not specified. Coming on to pooled blood components, we can pool both platelets and cryoprecipitates. Cryoprecipitates can be pooled prior to the storage or after thawing. So same group has to be pooled together. That's very important, ABO and RS type. And each pool shall have individual pool identity. A separate number has to be given. That's specifically written in that Gazette 2020. Or it should carry the numbers of all the individual units that has been pooled. And the origin of each constituent unit shall be retrieved in case of a look back. So you should have a good idea that which all components constituted this particular pool. And each pool should carry the expiry of the oldest constituent unit. So that's very important. So reconstituted blood components, we also issue blood for intrauterine transfusion for a lot of hospitals, maternity hospitals in Malappuram and nearby districts. So HCT should be more than 75%. O negative TRBC and AB positive FFPs are mixed. Here, the unit has to be radiated and leucofiltered prior to this being issued. And the sample has to be taken for HCT post reconstitution. It also requires a good technical expertise. So it's not easy to create a HCT at 75% because removal of all the additive solution, the complete removal is not that easy. It has to be done by a person with expertise, because you might feel that all the additives will come out, but it won't. So practically, even sometimes you might have to redo it to get the ideal composition. Next, coming on to apheresis. We use both intermittent and continuous systems technologies. As if now we are mostly hybrid, intermittent for the machine and continuous for the patient. So the physiology, Mohandas had gone through it deeply. The volume and number of components collected depends on the donor and the equipment characteristics. Anticoagulation, it is mostly citrate is used, especially for donor apheresis. It reduces ionized calcium. Citrate is later metabolized in liver, kidney, and muscle, releasing ionized calcium. It also, this anticoagulant citrate also leads to parathormone secretion, leading to calcium resorption from bones and renal absorption. Increased renal absorption. Fluid shift. Extracorporeal volume should be less than 15% of blood volume or less than 10.5 ml per kg. It can lead to vasovagal reaction or hypovolemic reaction as a result of this fluid shift. Cellular loss, platelet loss up to 29% during the SDP procedures, which can easily be replaced by splenic reserves. Red cell loss dictates the donor interval. Actually, how often the procedure has to be done is depend on the red cell loss that occurs during a particular apheresis procedure. So these are the requirements when you start a facility for apheresis. Minimum 10 meter square area has to be provided, which is actually not adequate for a good apheresis room. Actually, only a single machine could be placed. So if you have need a good area, more area has to be provided. Apheresis machine. So only the products with the machine you own can make will be licensed when you have a particular. If you are having a particular machine and a particular component cannot be prepared by it, that particular license won't be obtained, even if you apply for it. So the UPS supply has to be there. Trained staff training certificate has to be produced on the machine in use. So whichever staff is planning to use a machine, you will have to have a specific training certificate issued by for that particular equipment, and labels and SOPs also has to be provided at the time of inspection. So plated apheresis, the donor interval you are all aware of, at least 2 days, minimum 48 hours, two collections in a week and month, and 24 times in a month. When whole donation, 1 month in advance or after SDP is the time period. If reinfusion is missed, 3 months has to be taken care of. So if there is an antiplatelet drug, you have to consider that if the patient is taking one. Minimum weight 50, maximum age 60. Next is a controversial, you have to do CBC and TTA considering the cost of the kit. So when you have to do the particular test is a controversial topic, whether you can, it depends on the donor you will be having actually. If you have repeat donors, you can actually carry on with the procedure and you can opt for doing it as the procedure goes on. If you are having a fresh donor, you will have to do it before the procedure. That's how so the number of rejections which we had after starting the procedure are very less. And even vasovagal reactions are also very less for STPs compared to the whole donation. Pre-procedure, the platelet count of donors should be more than 1.5 lakh per microliter, and hemoglobin should be 12.5. So these are the standards: 3 to 10 to the power of 11 platelets per bag. 75% of the tested unit has to agree to that. 200 to 300 ml, pH more than 6. WBC count less than 5 to 10 to the power of 6 WBCs per bag. Red cell has to be, should be minimum. So these are the challenges which we usually face, whether to add a platelet additive solution or not. So in a center like ours, where there is always enough inventory of SDPs for patients, we can afford to have a platelet additive solution, because only then we can give these units across the group without much problem. The next is, so we, in most of the patients, cases we add pass into the SDP. Next is, you have to decide whether the kit stays in the blood bank inventory or the pharmacy inventory. So in small centers where the inventory of SDP is not big enough, they do SDP collection only when there is a requirement or when there is a request. So the problem with that is the effective management is pretty difficult. So in our center, we keep SDP in our blood bank inventory rather than in the pharmacy inventory. So testing the product or donor, which I have already mentioned, single, double, or triple collection. So that is very important. So usually our donors are well built. You can easily collect more than a single dose from each donor, and you should give it as 2 different units for 2 different bills. Only then revenue will increase. That is something that has to be underlined. Without revenue, no department will function, especially in a private center. Additional FFP. Whenever possible, get an additional FFP from each collection, and you can issue it for fractionation centers. And acceptance by the clinicians is a very challenging thing, which when we introduce this SDP as a new product into a hospital, usually they'll all be comfortable with the normal RDPs, and it takes time for the change, and you will have to have your own protocols or your own plans how to do it. I had my own plans. I don't want to speak about it over here, but it was successful, and you have to have your own plans for that. So this is one of the collection procedure which I have come across in another center, and I have adopted it over here. This, depending on the donor weight, donor height, platelet count, we increase the number of units. We even collect the FFPs. I don't stick to it for all the patients, but regardless of, however, we try to get more than 1 component from each apheresis collection. Only then it will be profitable. Only then you can bring down the cost of the SDP also. Otherwise, you will have to issue each SDP for almost around 16 to 18. That's beyond the standards that has been set by the NACO. And so unless you get more components, it's not possible to run it at a feasible manner. So plasmapheresis, serum protein has to be, when it is repeated, plasmapheresis is being done, serum protein has to be more than 6 gram per deciliter. It can be done as infrequent and frequent, monthly and fortnightly. 500 ml can be collected per sitting and 1000 ml per month. It is feasible only as convalescent plasma collection or concurrent plasma. Unless the cost of the kits that is being supplied by Thermo and Fresenius comes down, we won't be able to collect plasma as such and issue it for any particular indication. So it is feasible as convalescent plasma, or with a unit you can collect an additional concurrent product and give it for fractionation. Erythrocytopheresis. I applied for this particular component licensing, but they rejected. They wanted to repeat the inspection with a subject expert. That's what they said. They want to redo it because the person who came couldn't decide on himself. They will come back. That's what they said. So it can be collected as 1 PRBC, 2 PRBC, 1 PRBC plus 1 SDP or plasma. The PCV has to be more than 40% for double volume collection. Volume of PRBC per unit is more or less similar to the whole blood collection. Donation interval should be 4 months when we do for double volume collection. It's also economically unfeasible unless it is being collected along with SDP, because it doesn't make any sense. The cost of the kit is pretty high. considering the cost of blood that is being allowed for us to procure over here. So unless it is for reducing donor exposure, you want to collect two PRBCs from a single donor, it's not feasible. So granulocyte transfusion again, it can be done for life-threatening bacterial, fungal, yeast infections, neutrophil dysfunctions, waning. It is having waning importance because antibiotics, recombinant hematopoietic growth factors, higher complications due to this transfusion. HSC is replacing bone marrow transplantation. Actually, we issued few units for outside hospitals. For our hospitals, I don't remember issuing any granulocyte transfusions. So it's an if we are going for unstimulated collection, we'll get almost 0.2 to 0.8 into 10 to the power of 10. That won't be adequate. You'll have to give pre-dosage of corticosteroids, Dexa 8 mg or VCSF, and a consent has to be taken, collected after 12 hours of medication. 4 to 8 into 10 to the power of 10 we will get. Minimum it should be 1 into 10 to the power of 10. Minimum each unit should have. It should be radiated, non-leucofiltered. All products should be radiated. Cross-matched, and it should be ABO compatible as with granulocyte. Lots of RBCs will be there. The expiry is only 24 hours. Repeat transfusion required till the patient recovers. So that's a challenging problem because first of all, you require a license. Pre-medication, a lot of voluntary blood donors won't be willing for this pre-medication because of various reasons. These are the complications for pre-medication. The GCSF can lead to generalized pain, and Dexa can lead on to posterior subcapsular cataract. So most of them, so the patient's relatives will be the one who will be willing for this, and they will come, and you won't have enough donors, and repeat issue has to be done by the blood bank for that particular patient till he gets over it. So we'll have to have repeat collection from a particular donor. That's the challenging part, and there are no much standards for that. So I got this standard from Amrita, that's what I remember, and it's based on UK guidelines. Granulocyte to granulocyte is almost on 48 hours. We can do it. And granulocyte to SDP and SDP to granulocyte is 1 month, and granulocyte to whole blood and whole blood to granulocyte is 3 months. So this is a concise pictorial table representation of all the machines which we have done or used over here. The extracorporeal volume. The extracorporeal volume drastically varies among the machines based on the kits which we are using. That's very important, and the products that can be prepared from it. So various machines have various reasons. So one major thing is that when you are adding pass to a particular component, SDP, you can do it only at a machine where it is approved. So as much as I know, TMAS is only approved machine to do that. Otherwise, we have to do it outside manually. So these are the complications. I am not going much into it. You will all be knowing it due to time constraints. So this is the bad news. For the last 10 years, there hasn't been, for all these components, the government has given again a price list with no improvement, no significant improvement for the last 10 years. And that's a challenge. We as clinic transfusion medicine specialists have to do something regarding it, because otherwise our departments will never be profitable. Thank you. I welcome Dr. Linda, the Associate Professor from Amrita Medical College, for presenting her topic on cryopreservation technical aspects.
At the outset, I would like to thank the organizer of TMAS and Dr. Nitin sir and Arun, the Transfusion Medicine MVR, for giving me an opportunity to present here. Moving on to my topic, it's cryopreservation, the technical aspects. Being as a post-lunch session, this is quite a tedious work for me to take the class. So before that, I would like to know how many of you have seen the cryoprecision technique as such? Anyone? 2, 3. Okay. So moving on to it. So these will be the definitions which we'll be going through. So moving on to the definition, what is cryopreservation or where is it being done? So cryopreservation is the use of very low temperature, that is -90 or even up to -196, to preserve structurally intact living cells and tissues such that it remains capable of survival upon thawing. So there are various processes of cryopreservation being explained in the literatures. They are the slow freezing, which is the conventional cryopreservation, vitrification, sub-zero non-freezing storage, and preservation in dry state. So what is low freezing or conventional cryopreservation? That I'll be explaining in the next slides. Vitrification is a rapid freezing method where there's a sudden change from liquid to glass state. And sub-zero non-freezing storage is, it is going to the sub-zero temperature, but it's not non-freezing storage where it will be stored in a computer program incubator at -4 degrees Celsius. And preservation dries to the lyophilized state, which is not possible for the stem cells due to difficulty in introduction of cryoprotectant. Moving on to the history. Moving on to the history, the Paul Smith scientist, he introduced the 10 to 20% of glycerol for cryopreservation in 1949 for preserving the spermatids of the pork. And later in 1950, James Lovelock proved that the concentration of salt rather than the ice is the main cause of freezing injury to the cells. And it's Alexander Sadistin in 1866 discovered DMSO, which is the standard which we use for cryopreservation. So where do you do this cryopreservation? The indications are in case of autologous stem cell transplants. Mainly we use cryopreservation for autologous stem cell transplants in case of lymphomas. The two indications where you do autologous stem cell transplants are the PGs in lymphomas and multiple myelomas, where you do cryopreservation mainly in the lymphomas. Why? Because in lymphomas, they have 2 weeks of regimen, chemotherapy. So before they starting the chemotherapy, what we do is we take the stem cells and then we do cryopreservation. And after the chemotherapy is being done, then only we transfuse the thawed cells. How long you can keep the stem cells and what is the temperature where you keep the stem cells? Anybody? It is this according to EPBMT, European bone marrow transplant guidelines, you can keep the stem cells at 2 to 8 degrees Celsius for a maximum period of 72 hours. Beyond that, you cannot keep because the number of live cells and the duration of the stem cells will start getting deteriorating after 72 hours. So if you are starting cryopreservation, you have to do within 48 hours. And in case of, that's the case of autologous stem cell transplants. In case of allogeneic hematopoietic stem cell transplants, if the donor is in another state, autologous means what? The stem cells are collected from the same as that is the patient. Allogeneic means what? The donor is someone else and the patient is someone else. In case of if the patient is in remission and he is gone after some time, is going to relapses, this is the application of cryopreservation. If you cryopreserve, you can later transfuse to the same patient. And if the patient is in some other, if the patient donor is abroad, in that case also, if to space the time between the transfusion and the conditioning can be gapped with the application of cryopreservation. And another indication is cord blood stem cell transplant in case of clinical research and for a DLI, donor lymphocyte infusion also you can do cryopreservation. So just for you to introduce the allogeneic bone marrow transplants, it's been case of a donor, the stem cells will be collected through peripheral blood stem cell circulation after giving a mobilizers like GCSF or in Florixa. If GCSF is given, it can be given at 10 microgram per kilogram body weight for 5 days. After that, we'll start collecting the stem cells through the peripheral circulation that you saw how it's being done in the morning session. After that, we'll be doing the processing of the stem cells. And during chemotherapy, if it's been needed to cryopreserve, we'll cryopreserve. At the time of infusion, we'll thaw it and transfuse to the patient. So moving on to the mechanism. What is the mechanism behind all this cryopreservation? So as you all know, water is the major component of all living cells. So what happens? All the cellular metabolism stops when all the water turns into ice. So there are 2 types of cooling. It can be either called fast cooling or slow cooling. What happens in the case of fast cooling? all the cells will be all the water will be formed to ice intracellularly, which leads to rupturing of the cell membranes and rupturing of the cellular organelles. If it's slow cooling, all the ice will be formed outside cell membrane so that the solute concentration increases and it will also lead to cell shrinkage. So both fast cooling and slow cooling is not good. The good cooling is controlled rate cooling known as 1 degree Celsius per minute has to be done for preventing intracellular crystal formation, solute concentration, and for avoiding the cell shrinkage. So the freezing causes basically cellular dehydration, increasing the solute concentration and also intracellular ice crystal formation. So this can be avoided with the help of two mechanisms, that is by adding cryoprotectants and also with the help of using control rate freezers. That is, control rate freezer means the freezing at the rate of 1 degree Celsius per minute. So what are cryoprotectants? The cryoprotectants are basically used to avoid the rise in solute concentration and also to prevent intracellular ice crystal formation. It can also stabilize the cell membrane to prevent damage during the thawing process. It should have low toxicity, must be highly soluble in water and remain so even at very low temperatures up to -196. These are the basic properties of a proper cryoprotectant. So basically the cryoprotectants are divided into two types. They are the permeating types and the non-permeating types. What are the permeating types? As the name indicates, the permeating type of cryoprotectants will permeate the cell membrane and it will make the cell membrane more permeable and less toxic. It forms actually a hydrogen bond with the water. So these are the protective effects of the cryoprotectant. And permeability depends upon the concentration. The standard concentration which defines in all guidelines of the cryoprotectants are the 10% of DMSO. And optimal concentration is 10% DMSO. As the concentration increases, the literature says even if it goes increases to 40%, what happens is that there will be cell damage, increasing the cell pore size. So the ideal concentration should be 10% DMSO. And the examples for permeating cryoprotectants are the glycerol, DMSO, ethylene glycol, and propylene glycol. The non-permeating, they exert the protective effects outside the shell. It will not permeate, it will not go into the cell inside the cell. The examples are the PEG, polyvinyl pyridine, sucrose, and trehalose. So in a nutshell, what are the cryoprotectants? They can be either divided into colligative property or polymeric. Colligative property, as I've already defined, protection of the cells from ice formation, dehydration. Polymeric are macromolecular substances which provide a glassy shell, protected shell outside the cell. So basically the cryoprotectant prevents ice crystal formation and cell shrinkage and solute concentration. If you are using colligative cryoprotectants like DMS and glycerol, it protects from inside the cell. Now outside, if you're using a polymer like hydroxyethyl starch or pentastarch, it provides a protective coating outside the cell. And if other things which you have to add into the cryoprotectant mixtures are the plasma proteins or solvents. What are plasma proteins? They can be used as autologous plasma or conventional, or you can use commercially available like albumin. They reduces the cryopreservation injury, and the solvents you can use are the saline solutions or sugar solutions. It provides a suspension of cells or it can be acted as a diluents for cryoprotectants. Now going on to the steps of cryopreservation, what you know is the cryoprotectants mixture, the amount of cryoprotectants which are used. Each hospitals have their own protocol of cryopreservation and cryoprotectants, and the addition of cryoprotectants to stem cells and how you keep the storage, the freezing, thawing, and infusion. The first step is the processing. As Mohan sir has explained the morning section, after you collect the stem cells, it will be done processing. That if the RBC contamination is high, in case of major mismatch, what will you do? RBC reduction has to be done. In a minor mismatch, what will you do? Plasma reduction has to be done. Or otherwise, also to reduce the DMSO toxicity, after collecting the stem cells, it has to be volume reduced. That is what we call the first step is the processing. The second step is the cryopreservation. The cryoprotectants has to be prepared and it has to be added to the stem cells. The main cryoprotectant which you add is the 10% DMSO. After adding the cryoprotectant to the stem cell, what you do is it has to be kept in the freezers. Freezing procedures. There are various types of freezing procedures. What are they? It can be kept either in the -80 degrees Celsius, that is what we call dump freezing, or it can be kept in the vapor phase or liquid nitrogen tanks. What is the temperature for vapor phase? It is -154 and liquid phase is -196 degrees Celsius, which is a standard method of freezing. It is a liquid phase. I hope you might be knowing the basic difference between the liquid phase of nitrogen and the vapor phase of nitrogen and the -80°C. Then after freezing, you have to thaw at the time of transmission, and after thawing, you have to check for the QC, quality control. So moving on to the procedure as such, what are the materials you require for cryopreservation? So various hospitals comprise various protocols. This is my protocol, Amrita protocol, which I will be explaining. At the time of demonstration, the MVR protocol, they will be explaining and demonstrating to you. So our protocol requires the materials are the 20% pentastarch, 25% human albumin, and 100% DMSO. Before going to the procedure, you have to consider this as a purely sterile procedure, as if you are going to a theater as a surgeon. You have to take a proper hand care, hand hygiene, and biosafety cabinet, as you know, the laminar hood where you do the procedure. You have to wear a sterile apron and sterile gloves, mask, and hair cap. Everything has to be worn, and you have to clean the biosafety cabinet, and you have to switch on the UV ray before the 30 minutes of procedure. Make sure that everywhere is very sterile and highly clean. And this is the second picture is the cryo vial where you take the samples for QC purpose. This is the Duran bottle. So I will show the pictures first, then only I will explain the procedure. You have to know about the each items which we will be using for the procedure. This is a sampling spike. This is a metal canister. After we add the cryoprotected stem cells, we will be keeping the stem cells in this metal canister. This is the cryo bag where we will be adding the cryoprotected stem cells into the cryo bag. This is the overwrap. After adding the cryoprotected stem cells, this cryo will be kept in this overwrap. So moving on to the equipment which you require for the procedure, this is the control tray freezer, which is a standard method where we go into the low temperature at the rate of 1 degree Celsius per minute. This is the liquid nitrogen tank where we keep the added cryoprotected stem cells for storage. This is the additional nitrogen tank which we have for the continuous supply of the nitrogen. This is an additional thing which we have because if the nitrogen in the nitrogen tank goes down, there should be some alarms. For the continuous supply of the nitrogen, we have an additional tank, so this will be automatically filled. This is a manual plasma extractor that everybody will have seen. This is a sterile counting device or docking device. This is the balance weight which we have for calculating the weight. So moving on to the procedure, the first step is the preparation of cryoprotectant. The next step is addition of cryoprotectant to the stem cells. The next step is after adding, it has to be frozen. That is at the rate of control rate freezing. Then we keep it in the storage. We can keep it either in -80 degrees Celsius, that is down freezing, or if you have the facility, you can keep it in liquid phase or vapor phase. These are the basic steps. So we're moving on to the pre-processing setup. You should have adequate labels for writing the volume of the stem cells, the name of the patient, the date of cryopreservation, the gases, canisters, vials, everywhere you have to write it. You should have adequate labels. Determine the constituted stem cell after collection and also after volume reduction. And the cryoprotectant is added in the ratio 1:1. If you have 250 ml of stem cells, you will be adding 250 ml volume of cryoprotectant to that stem cells. So everywhere they will be taking the 1:1 ratio. So moving on to stem cell procedure product preparation. First, I said there is volume reduction. Before that, I told you it is kept at normally for how long you can keep it at 2 to 8 degrees Celsius for 3 days. That was according to EPTMT guidelines. So the stem cells they usually preserved at 2 to 8 degrees Celsius. For pre-cooling, the centrifuge has to be shifted to 4 degrees Celsius. For that, we do pre-cooling. After pre-cooling, what you do is you have to do the next step is volume reduction. This is a stem cell after collection. For the volume reduction, the stem cell bag has to be connected to the transfer bag with the help of a sterile connecting device. So I connected with the help of sterile connecting device the stem cells with the transfer bag. So this is how it will remain. So the connection has been done, and you have to weight it and balancing, and you keep it in centrifuge. And it has been centrifuged at 300 RCF, 10 minutes at 10 degrees, 10 minutes duration. And this is the after volume reduction, this is how it looks. This is the stem cell layer. You can see in the picture. Can you all see? This is the white cells. You can see this is stem cells which you are seeing after the spin. The above is the autologous plasma. Why am I doing this volume reduction? To reduce the cryoprotectant level so that during transfusion you can reduce the DMS toxicity. So this is an important step where you are reducing the unwanted autologous plasma. So with the help of manual plasma extractor, what I do is I remove the plasma from the stem cell mother bag and the remaining is the stem cells. Understood? And after that, you have make sure you are weighing after stem cell collection, before keeping in the centrifuge, after volume reduction. So this is the reduced after reduction. This is the weight of the stem cells which we are having showing 245 ml. So this is our protocol. This is our institution follows this protocol to prepare 52 ml of cryoprotectant. The constituents, you can remember, I remember it is a short form pneumonia as FAD, FAD. That is 20% pentastarch, 31 ml. Human serum albumin is 25%, 16 ml. 100% DMSO is 5 ml. What I said is the DMSO after concentration should be have how much? 10% DMSO. So if you are preparing a 52 ml of cryoprotectant, if you calculate 5 by 50 to 100 will approximately lead to 9.6 to 10% DMSO final concentration. Understood? So if you're preparing 104 ml of cryoprotectant, how will you calculate? It has to be all doubled. So if we're preparing 52 ml, if you are having a 50 ml of stem cells in your mother bag, you're preparing equivalent amount of cryoprotectant, like you're preparing 50 ml of cryoprotectant. Understood? If your stem cells are having 104 stem cells in your bag, you have to prepare equal amount of cryoprotectant. So this is the mixture ratio. My constituents are 20% pentastarch, 25% human serum albumin, 100% DMSO. Clear? So how we are preparing is, I will show the picture. Before going to preparation, I told you the biosafety cabinet has to be sterile, make sure it's sterile, and all the procedures are being under on top of ice packs. Why? Because stem cell temperature is 2 to 8 degrees Celsius. So you have to place the ice packs on top of it. You place a sterile sheet, and then you have to chill all the materials before doing the cryoprotectants. All the cylinders, all the preservatives, all the bags, everything has to be kept at 4 degrees Celsius before doing the cryopreservation procedure. And you have to arrange like this, and then only you should start the procedure. So after keeping the fridge refrigerator for 2 to 4 degrees Celsius for some time, and then I will start the procedure. The first step is taking the pentastarch. So I have taken the needle with the 18 gauge needle is attached with the 20 cc syringe. From the bottle, I will aspirate 31 ml into the required amount of volume is aspirated in the syringe. And next step is you are taking what? Albumin. That is in the ratio 16 ml. And next you are adding DMSO. DMSO also we will keep in the refrigerator. If you keep it for a long time, it will start crystallization. For avoiding that, just add this is the next step. Prior to 5 minutes, we'll keep the DMSO in the fridge to prevent crystallization of DMSO. Okay, like one by one, we will add these things into this is a Duran water, the glass bottle, where you add each cryoprotectants. First step is adding of pentastarch. In the picture, you can see through the sides of the glass bottle and injecting without the needle. Through the sides of the bottle, you are adding the cryoprotectants one by one. First, you add the pentastarch, then you add the albumin, and then final step, you will be adding the DMSO. While adding each one, you have to shake it, mix it properly to homogenize the mixture. The final DMSO will be added very slowly and gently after mixing each step. Why? If any crystals are formed, it will affect the viability. All these steps are very important. It has to be added slowly without any air bubbling and without any crystallization. You should always make sure that this mixture is homogenized. And after the preparation, like this, you have to overlap with the aluminum foil to prevent any exposure to sunlight. You have to keep it a minimum period of 30 minutes in the fridge before starting the next step. Why? DMSO is being exothermic, you will start producing heat. So to stabilize the cryoprotectant, you have to keep in the fridge for a period of minimum 30 minutes. You can keep it up to 1 day, 24 hours. Next step is addition of cryoprotectant to bag. So for this, again, you have to arrange the biosafety cabinet like this. These are the cryo bags, which you can see in the picture. In one pouch, there will be 4 cryo bags. This is the 50 cc Luer-Lock syringe. This is needed. Luer-Lock means it has grooves. If you see very closely, you can see grooves because this syringe can be connected to the bag. You can see here. So what you have to do is take a 50 cc Luer-Lock syringe, remove the piston and take it in the upright position. And this is the spike which I showed initially for the materials required. The spike can be connected to the stem cell bag. This is the volume reduced stem cell bag which I had kept it in 2 to 4 degrees Celsius. I've taken it from the fridge and then you spike it with the spike is being connected to the stem cell bag and you can see the clamp here. You close it and connect the syringe through this way and you keep it in the upright position. And then if it is 250 ml, suppose it is 250 ml stem cell, you have to make 250 ml of cryoprotectant and then removing the top of the Durant bottle, you pour it through the syringe. Got it? This is how you add. Then you unclamp this one, so it will slowly go down to the stem cell bag, so that you have to mix it at the same time with the hands, so that there will be adequate and equal amount of stem cells will be mixing to the stem cell bag. All these steps are very important because if you are not doing it properly, there will be crystal formation. It will affect the viability. Now, after proper mixing of the cryoprotect with the stem cells, what you have to do is you are taking some amount of stem cells into the syringe. After taking the stem cells in the syringe, again you have to push back. This is how we proper mixing of stem cells with the cryoprotectant. After 2 times, if you mix it like this, then only you have to take into the cryo vial for taking the QC. Why? If you do not mix the stem cells with the cryoprotectant in proper manner, if you take the cryo vial for taking QC, it will not be representative of the proper mixing of the stem cells. Each of the steps are very important. And the first sample always you should take for QC. So the first, I have taken the 2 ml vial. In that, I will be putting around 2 ml for taking the viability check. And after that, this is the, after that, these stem cells in the syringe I will be pushing into the cryo bag. This is the cryo bag with the stem cell in it. You have to label everything, the date of cryoposition, the volume of the stem cells you are adding. Everything has to be marked correctly. Now the next step is control rate freezing. So what you do in the control rate freezing, the starting temperature is the stem cells. I told you we are doing all the processing on top of ice packs. So it will be 2 to 4 degrees Celsius. So in the control rate freezer, we have brought in such a way that our protocol follows these steps. The 1 degree Celsius per minute up to -5 degrees Celsius, and then 2 degrees Celsius per minute up to -60 degrees Celsius. -10 degrees Celsius per minute up to -150 degrees Celsius. So all these processes will take approximately 45 minutes. So after 45 minutes, the stem cell temperature from 4 degrees Celsius will reach up to -150. After -150 degrees, 160 degrees Celsius, the machine gives an alarm. So that means the completion of control rate freezing. If you don't have a control rate freezer, what will you do? Not many of the places will be having control rate freezers. So what they can do is, after addition of the cryoprotectant, they can immediately transfer the product to the dump freezer or mechanical freezer -80 degrees Celsius. Or what they can do is, if they are having a vapor phase, they can keep it in vapor phase latent nitrogen. These are the various methods what you can do for storage. So this is the control freezer inside. This is the control freezer planner which we have. The inside will look like this. So after placing the stem cells in the metal canister, in the previous picture I've seen the cryoprotectant the stem cells. So the cryo bag will be packed, will be inserted into the which bag overwrap for preventing any breakage, and the overwrap will be placed inside the canister. This metal canister is packed with stem cells with the cryo bag along with the overwrap, and I've placed inside the control rate freezer. This is a control rate freezer, and control rate freezer is attached with the graph. So after starting the enter button, it will automatically plot a cool graph. That is also a QC. It is mandatory for each program. You will be having a graph along with that. Any control deviation will show the temperature fluctuations. If there is any breakdown for the control freezer, this graph will show it, and there will be alarm. At that time, what will you do? According to WHO, there are several guidelines. They say if there is any problem, any breakdown happens, you can immediately shift to the -80 degrees Celsius. Or if it is, you can have the liquid nitrogen next to you, we can immediately shift the stem cell product to the liquid nitrogen. Okay. This is the 30-liter liquid nitrogen tank which is connected to the control rate freezer. The control rate freezer also requires liquid nitrogen. So this is study from our India only, Satyamara's study. There they have done study in autologous transplants of 51 patients over a period of 5 years. They have not done it in the control rate freezer. They have done it in uncontrolled freezer, dump freezer. They have got a recovery of 92.9%. So that can also be done in resource processing. If you have a facility, you can keep in minus 80 degrees Celsius also. The next step is transferring the frozen acid to the storage tank. This is the storage tank where we keep this is how you keep the metal canisters has to be placed in the metal racks. After placing in the metal racks, you keep the metal rack inside the nitrogen tank and you have to label everything, the position, the patient name, MRD over here. Otherwise, you will not know after some time which patients, which cassettes. So you should maintain a register also for writing all the details. And after that, this is the, I told you, for continuous supply, you have an additional tank because if there is any shortage of nitrogen, it will affect the viability. Records have to be maintained. So for calculation, I told you, for preparation 104 ml of cryoprotein, how you do it? You have to multiply it, double, 31, 62, 16 will become 32, 5 will become 10. That's how you make the calculations. So every time, everywhere, everyone will be adding the cryoprotein, the ratio of 1:1. The protocol will be different. So how do you divide bag allocation? Because each patient will be having different volume of stem cells. So how you calculate the required number of bags? The cryobags comes basically in two volumes, 250 ml or 500 ml. If it is 250 ml capacity, in one cryobag, the maximum you can keep is 70, minimum is 30. So the range is 30 to 70. We keep in the range of 60 to 68 because once frozen, it will expand. So after expansion, the time of thawing, the stands for breakage. In 500 ml, the capacity is between 55 to 100. So the number of bags required you can calculate approximately as divided by 60. If for example, if the volume of stem cells we have taken as 240, the number of bag required will be what? I told you roughly you can calculate in one bag as the volume of 60 ml. 240 by 60 will be the 4. So you will have to take 4 bags. So the various cryoprotein protocols which I am mentioning is some other hospitals will be following different protocols. For 100 ml cryoprotection, you can use 10 ml saline, 20 ml DMSO, 5 ml albumin, or it can be in a ratio 60 ml plasmalite, 20 ml DMSO, 20 ml albumin, or it can be like plasmalite alone, 80 ml and DMSO 20 ml. So our experience, we have done since last 3 years around 33 cryopreservations. Of that, allogeneic transplants was 23. At autologous transplants 10. Our viability for allogeneic is varying from 92 to 100%. Viability of autologous is 87 to 99.3%. We have done in another protocol from 2016. The number of cryopreservations we have done is 18. So moving on to factors affecting the efficacy of cryopreservation. It's mainly 2 points I highlighted already: the slope, the control rate freezing, and also the type of cryopreservating agent you are adding. It has to be ideally 10% DMSO. The contact of stem cells with DMSO before freezing and thawing. The DMSO should not be, the contact period has to be less at the time of thawing. And how do you thaw? After I have explained to you till storage, the time of transfusion, you have to thaw it. How you thaw? It's like so you need a thawing bag. It has to be filled with distilled water. You should have calibrated thermometer for checking the temperature. You're throwing it at 37 degrees Celsius. You take each cryo bag which is required for transfusion. The transfusion is done at throwing is done at the patient's bedside because to reduce the contact period of DMSO. Then transfusion, the throwing usually requires around 5 to 8 minutes. The transfusion rate is 10 to 15 ml per minute. Usually the transfusion has to be completed within 20 minutes. Understood? So the DMSO contact has to be reduced because if prolonged DMSO contact is there, it will affect the viability, the cell concentration. Cell concentration, high cell concentration up to 5.6 10 to power 8 cells cryopreserved is well tolerated. If it is more than that, as Mondos said, maybe if cell contamination is there, like granulocytes or other cells, high concentration can all affect the viability because more cell concentration, the cryoprotein ratio will not be adequate. So it will affect the viability. And presence of mature cells. that is the platelets or the granulocytes, RBCs are there, it can affect the viability and also the transfusion reactions can happen because granulocytes are released peroxidase. RBC contamination there can affect the patient. So what are the challenges? The few challenges what we have observed is crystal formation in DMSO. I said all the cryopretenants before doing the procedure has to be kept in the refrigerator for chilling. To keep the DMSO for more than 10 minutes or more than 5-6 minutes start crystallization. So crystal DMSO cannot be added as a cryoprotectant. And also while adding the mixture, you should avoid bubbling and also crystal formation in the DMSO. That's very mandatory. Another one is breakdown that I already explained. While doing the process, any breakdown you are noticing, you can do is what you can do is you can keep it in dark freezer or you can immediately shift to the liquid nitrogen. And another one is the nitrogen level. Nitrogen level is once if it happens is very important to make sure that you have to check the temperature and nitrogen level every 4 hours. Every 4 hours it's mandatory. You have to keep a chart like a thermograph you keep in the blood bank. You have to keep a chart. You have to monitor the temperature and also the nitrogen levels. So for that, you can attach additional nitrogen tank to the storage tank so that there will be continuous supply of nitrogen. And also there should be high level, low level alarms and remote alarm notification. If you can use a data logger also for the automatic filling. Now, viability of cells is another challenge which everyone will face. So it depends upon the type of cryoprotectants, how the process is being done, the exposure, the DMSO has to be added slowly with shaking all the time to prevent crystal formation. And I told you that cryoprotectants to homogenize and to stabilize which have to be kept after preparing within 30 minutes in the refrigerator, and also the whole procedure after adding the cryoprotectant stem cells, the remaining all procedures, that is freezing and keeping the liquid nitrogen tank has to be completed within a time frame of 30 minutes according to EPBMT. That is very important. If you exceed that time limit, there stands for loss of viability. So improper cooling rate, post-freeze temperature fluctuations, improper thaw, incorrect cell density can all affect the viability detrimentally. Breakage of bags at time of removal from liquid nitrogen can also happen. That only we have faced. I think I have asked many centers. The time of once what happened is that we had almost filled the liquid nitrogen to or not up to the brim high level because we didn't have the we had a shortage of nitrogen at that time. So what happened is that when we took the nitrogen, when we took out the cryo bags with the metal rack outside, the bag was that canister was fully filled with liquid nitrogen. So immediately when we took it out from the liquid nitrogen and we were like reading which bag which is that we are checking with that time we started bursting. The metal canister itself started exploding. But luckily, because of the overrun, nothing happened to the bag. We immediately shifted to another bag and kept inside. That happened for 2 to 3 times. So what I understood is that when we take the liquid, the metal bags from the liquid to the vapor phase or to our temperature outside, there's a transition from the liquid and to vapor that expansion is being happening. So if too much of liquid nitrogen is there in the metal canister, it can burst. So to avoid that, don't keep the liquid nitrogen levels too high, and also don't keep the metal canisters outside also for very long time. So immediate shifting of the liquid nitrogen from the tank, from the storage, and you have to keep immediately into the cold box for avoiding that temperature fluctuation and liquid to vapor phase transition. So with that, our problem got solved. Before that, we had that issue 2 or 3 times. And another issue, what you can happen is breakage of cryo bag at time of thawing. You can make sure it's only at time of thawing, because in the frozen state, you might have noticed for plasma bags also. Because after freezing, you will not know whether it's any crack or anything is there. Only at the time of thawing, you can see any leakage will be there from these stem cells. So what you have to do is always make sure that to use the overwrap for the stem cells, so that if any breakage is there, it will flow into the overwrap. It has to be sterile. Again, you have to keep a Ziploc bag while thawing so that it will be sterile. Any waste stem cells are not going to be discarded because it's very precious, like organ transplant. Under antibiotic cover, they will be transfusing the stem cells. And next one is clots in stem cell after thawing. This also is not in our center. I've seen some other centers having clots. That's how you can, one thing is at the time of stem cell collection, you can monitor for any clots. If you are seeing any clots at the time of stem cell collection, what you do is you have to change the ACD ratio. You have to increase the ACD ratio so that there will be no clots while stem cell collection. And there can be clots at time of thawing. So at time of thawing, what you have to do is you have to generally knead the stem cell in between. And you have to knead it, so make sure that there will be no clumps. If you're not doing it properly, or generally kneading is not there, that can cause precipitation, clumps can be happening. Third factor is due to the high cell concentration and also cellular contamination like granulocytes or RBCs are there. It can also lead to clumps formation. So for avoiding that, you have to follow all these steps. These are the usual challenges what we have faced or what I have seen from the literature or from other hospitals. So moving on to the adverse effects. Generally, you can see some of the adverse effects during transfusion, but main adverse effect is due to the DMSO toxicity. The DMSO, the tolerant level, this have to know all the PGs, it's 1 gram per kilogram per day. More than this, you cannot tolerate. Okay, so the side effects mainly, it's a cardiotoxic, as you all know, DMSO. It usually causes what sinus erythemias, but most usual complication which I have faced in literature is nausea, vomiting, abdominal cramps due to histamine release. So to avoid that, what you can do is you can pre-medicate and then start transfusion. You can give antihistamines. So method to reduce toxicity are you can reduce the low dose DMSO by adding polymers like pentamel, HES, pentastar like that. And DMSO washing is another one. So the advanced in DMSO washing is a standard protocol is New York Blood Center protocol, which includes two-step addition of 2.5% albumin and 5% dextran. And the recent advances washing, what I've seen is a lower device automation has been come up for washing DMSO, but it has a drawback. It is having a loss of 30% up to 31%, not this low in general washing. If the patient is a non-cardiac patient, if the patient is having unavoidable situation, you have to do washing. That's generally not advocated in many centers. Moving on to quality control, my last slide. Maintenance calibration has to be done, and QC of concentrate freezer. I told you about the cloth, the pool weight, the freezing curve should be kept documented with each patient's records. Microbial cultures can be done. Nucleated cell count. Already Montessori has said about all these. Cell viability is mandatory according to European BMT guidelines. What says the cell viability is has to be more than 50%. It should not be less than 50% for transplant. If you have to take in consider the EPBMT guideline says this international guideline has more than 50%. Our institution follows the Vancouver, which is followed in the Carolina Hospital. Our hospital post cryopreservation thawing, the QC has to be more than 60%. Then only we take up a transplant. So if at the time of stem cell collection, we check the viability has to be 90%. Post cryopreservation thawing, it has to be minimum 60%. EPBMT guidelines says should be more than 50%. The cell viability is our protocol is using 7-AAD. Today also we saw the method. Coliform cell assay is another one. It is usually takes 2 weeks. So we many of centers are not doing because of that. So to conclude, DMSO has always remained the gold standard cryoprotective agent as the rate of concentration 10% for many different cell types. Regardless of cell types, the success of any cryopreservation protocol is dictated by type of cryoprotective agent used as well as appropriate cooling and thawing rates. Development of more efficient procedures for cryopreservation of cells, good manufacturing practices, complaint containment systems may further expand their clinical applications. These are my references, and thank you. This is my BMT transplant unit. Thank you for patient listening.
We thank Dr. Linda for that wonderful presentation on cryopreservation. We are already running behind by time, so we'll quickly move towards the blood bank and complete the other demonstrations.